support, we can go online.
Sir, please start in 3, 2, 1. Please start, sir.
Good evening and very warm welcome from Zuventus Healthcare Limited to all the doctors who are attending this webinar. Today again, we are very proud to host our beloved teacher, Dr. P C Mahapatra, for his next session in the series of the continuous training which he is giving on his surgical skills. And he's every time coming with newer ideas and newer experiences which he had during his all days of surgery, and every time we are gaining more and more information out of him. So this time we thought we'll take a small break, and we will give him the other role of asking certain questions from us. One of the very important drugs which Dr. P C Mahapatra also likes is atosiban. And we would like to share a few slides with you on some of the new data which has emerged on atosiban. And with the permission of Dr. P C Mahapatra, we would like to start the session. Dr. Mahapatra, please.
Yeah. I think this is a good forum so that it's not a new drug, but a very effective drug. That's a thing I have, for the last few years, I've used this particular molecule, and particularly the preterm labor and all that. Initially, we abide by your guidelines by the Juventus, and you have to use a number of vials, at least 9 vials, and 45 hours and all that for a preterm labor, established preterm labor. But practically, it's not possible in a country like India. The cost effectivity and other things are the real major source for that. And therefore, we try to modify. India genius is indigenous. So we try to modify this and try to reduce the cost and used it in a smaller dose for that. So 2 things, short dose and ultra short dose. These are the 2 things we have changed in our practice, in which we have reduced from the 9 vials to 3 vials, and 3 vials is enough for that, and that is quite well effective and accepted by the people for that. And second is an ultra short, which I tell that in majority of the cases, a pregnant woman in her pregnant career presents to the doctor with acute pain, abdomen and all that, and that usually everybody has started some tocolytics and then admit the patient for half a day or 1 day and then discharge the patient. So the initiation process has started, but is not fully established, and maybe that spontaneously it resolves, or because of the tocolytics it resolves for that also. Yeah. So once it resolves, then it continues. Otherwise, that initial thrust and trigger, if you do not arrest that converts into a established preterm labor, and by the time established preterm labor, the cervical changes are there. It's very difficult to control that. So initially, I have tried some of the cases because of the cost factor. Also, I'm very conscious about it because I'm Aadmi ka doctor hu, and I'm practicing in a very place where people are not rich, and there I use the 0.9 ml, 1 ml. 1 ml, say 0.9 ml is a preparation which is available in your contrast, or in a multiple dose vial, multiple of 5 ml, I use 1 ml. 1 ml direct push during the start and all that. And believe me, surprisingly, I found that this initial dose of 1 ml is sufficient to arrest the labor. Practically, the nature's process and triggering effect is lost, and they are completely all right for that and continue rest of the time. Many cases they do not present also again, and in some cases they can come after 4 weeks and all that, and with the same thing, and again we can prolong it. But a prolongation of 1 week is also matters for the fetal survival, and that's why with spending a very less amount and all that, if you see that this is best for the patient, for the cost also, and this is good for the Juventus also, because the country is so large that a 1 ml everybody uses it. It will be more than your 9 vials use recommended guideline for that also. So that's the main thing. We are mainly concerned with the result, with the efficacy and cost. So these are the things which I have experienced and modified the dose. But the conventional guideline dose, very rarely we can use it and all that. And initially we tried, we failed. And then subsequently, I discussed with Bhupesh, I discussed with many of the doctors, and that's why we changed that the short, long, short and ultra short. 3 types of protocol we can use it. And the short protocol is very good for the atosiban for that. Then second, lastly, I must say that we have an extended use. Extended use right from the preterm labor also. I thought that it should be used in IVF pregnancy. IVF pregnancy is a very valuable pregnancy. Embryo transfer, there occurs uterine contractions and all that. And uterine contractions, I think now I'm routinely in all my IVF, in all my ET, I use 1 vial. 1 vial peri embryo transfer period of 3 hours use is really beneficial for that also. And many of the IVF people have asked that you try, use and all that. It's not an empirical, but use it and then find it out whether the results are good or not. I think these are an extended use of atosiban. I thank you that atosiban you have brought it, and it's good. I'm happy about the atosiban. The only thing is about the cost.
Yeah.
Thank you.
Right, sir. Thank you so much, sir, for sharing your experience on atosiban. Sir, we have conducted one study over here, and we are just trying to share the results of that study in a few slides. We make this session open for all the audience, and they can ask the questions, they can type the questions, and we'll answer those. So this is the evaluation of atosiban therapy in the management of preterm labor. As sir has said that the single vial has become very economical for the patients to use. But since this was based upon the international guidelines, we have used 9 vials plus 1 1 ml vial in all these cases, and we are just going to share the results with you. Sir, this is published in Journal of Advances in Medicine and Medical Research. And this is a study on 212 women with preterm labor between 24 and 36 weeks of gestation. And the study results are really very, very favorable for all. I'll show you a few interesting aspects about this particular study. Now, you see, in this particular study, 99% of the patients did not require any additional tocolytic. They didn't require any beta agonist. They didn't require any calcium channel blocker. They were simply given atosiban and they were having quiescence of the uterus. So there was 84.88% efficacy at 48 hours and 74.15% efficacy at day 7 also. So this efficacy was sustained. And the most interesting part, I would say that 29 days were gained on an average, by using this particular tocolytic agent. You see, the effect of uterine quiescence, or based upon the cardiotocography we saw, it becomes like from 4.3 to 0.67 within no time, and it is sustained at 48 hours, it is sustained at 72 hours, it is sustained at 7 days also. So we'll show you the data in coming slides. And the perinatal outcome is also very, very pro for this agent. The Apgar score of more than 7 was achieved in almost 95% of patients after 5 minutes of birth. So this shows that this drug is not having any harmful effect on the fetus. It is very well tolerated drug both by the mother as well as the fetus. Now, in this case, we studied the results at 48 hours, 72 hours, at day 7, and up to delivery. So that is after 7 days, we have kept the data up to delivery. Over here in this slide, particularly if you see the twin pregnancies, like, there were 13 twin pregnancies out of this 212 patients. And if you see their success rate, 9 out of those 13, they survived beyond 7 days. So surviving twins for a preterm labor is very, very important aspect. And most of the time, many of the drugs, they fail. But this drug is absolutely effective in twin pregnancies also. Of course, in singleton, it is showing a great efficacy. And in our study, we had both nulliparous and multiparous patients. And if you see, almost 113 patients were having the cervical dilation of more than 2 centimeter at the onset, at the beginning, and it became quite within few hours and remained undelivered up to day 7. Now, this is the percent of patient remaining undelivered at 48 hours, 72 hours, 7 days, and beyond 7 days. You can see this number is astounding. This number is so good, like, as Dr. Mahapatra was saying, that this drug with a single injection also retains the fetus in the uterus for a very long period. It is not that it loses the effect as the drug wanes off. Rather, it quietens the uterus to a great extent, and until a natural agent strikes again, the uterus remains quiet and the pregnancy continues up to delivery with normal delivery without problem. This perinatal outcome, again, we are showing over here. If you see that gestational age at delivery was 35.1 weeks, which is quite good. And the time gained in utero on an average was around 30 days, 29.15 plus minus 1.82 days to be precise. And gestational age at admission, less than 28 weeks, were like 52 on average cases, and the percentage wise. And days gained according to gestation was like singleton pregnancies gained 30 days and twin pregnancies gained on an average 15 days of pregnancy. So this is very effective thing, and that much saving is also there from the neonatal ward for the baby, and perinatal care becomes easier when the child retains in the uterus for a longer period of time. The characteristics of the patients, as we have discussed earlier, so this is summary. We are going to share the PDF of this whole study with all of you on Monday. Mr. Bordula will send you the emails. Changes in maternal characteristics after treatment with atosiban. If you see cervical dilation, from 2, it has become 1 and remained 1 at 72 hours. So effacement was reduced to 20% and contractions became nil at 72 hours. The neonatal birth record also was very favorable, as we discussed earlier. The APGAR score was very favorable. 95% was the APGAR score at 5 minutes of more than 7. Now, few of the neonatal mortality characteristics, we did face some mortality, but this was not linked to the drug. But these 8 cases were seen out of 212, which is on average the normal case otherwise also, which happens during the control or normal delivery without the agents. There was no blood pressure fluctuation, so no hypotension was seen, and the fetal heart rate was also maintained quite well without any changes. Now, another study I would like to discuss over here. This is from the Command Hospital, New Delhi, where 150 singletons were involved, 24 to 34 weeks of pregnancy, and full dose of atosiban was given over here also. Now, very interesting features that if you can appreciate, that 97% efficacy was seen and 93% pregnancies remained undelivered for more than 7 days. No fetal adverse events were reported. So 98.6%, that is out of 70 twin pregnancies, this was the outcome. Gestational age at delivery was 34.4, almost 35 weeks, as we seen in our case. And in IVF pregnancy also 98.18% efficacy was seen. So time to stop contraction always remain a question. And in this particular study, this was specifically noted that at 3 hours, 22%, 6 hours, 61%, and after 6 hours to less than 12 hours, almost 94% patients this experienced absolutely quiescence of the uterus. So beyond 12 hours, of course, the percentage increased, but to a small extent. So you can see that this is a very, very effective drug in case of preterm labor, to prevent the preterm labor. all the international guidelines, latest guidelines including, they are all preferring this as the first line agent for the control of the preterm labor. So to summarize, 85% tocolytic efficacy of atosiban at 48 hours without additional tocolytic agent, almost 75% efficacy at day 7 without any additional tocolytic agent. I'm repeating, 92% efficacy in twin pregnancy. Mean number of days gains is almost 30 days. Mean gestational age at delivery, 35 weeks. Frequency of contraction reduced from 4.3 to 0.67 at 72 hours. 41% neonates with birth weight more than 2,500 gram. 95% had EPGAR score more than 7 after 5 minutes. No serious adverse events were reported. So with this, I would like to open the session for questions, and you can write the question and we'll take the questions probably once Dr. Mahapatra finish his teaching for the day. And I would like to definitely have the comments from Dr. Mahapatra on these slides. Dr. Mahapatra, please.
Thank you, Dr. Dewan, that you have done this publication and all that. But I have some queries and all that.
Sure.
I am happy, but make me more happier. So the thing is that you have used the number one is the full dose, 48 hours. So that is one part and all that. Then 48 hours and 7 days. 7 days, all international publications also say that, yes, this has studied up to 48 hours and 7 days, this is there. And this is good in one aspect, that the fetal maturity. You gave a steroid, antenatal corticosteroid also during that time, and therefore that is one. Or transfer to the higher centers. So this is a major, this is an advantage. These are the two main advantages of prolongation beyond 7, up to 7 days. But at the same time, you have mentioned that 29.1 days is a mean duration of prolongation. I want to know, out of how many percentage crossed 29 days? That's the important part which is concerned for that. Second important, which I found, that the degree of dilatation less than 2 centimeter and more than 2 centimeter. More than 2 centimeter dilatation, we around 50 something, 54% or something you have quoted. And less than 2%, 2 centimeters, around 70, more than 70%. I think this is logical. This is logical because you are using in preterm labor, established preterm labor. So the use of atosiban can be divided into threatened preterm labor and established preterm labor. In threatened preterm labor, short course can be an option for that. But the established preterm labor, this is one important aspect for that. But main thing, I'm not happy with the 7 days duration, 7 days at the end of 7 days. I will be happy if it prolongation, majority of the cases, about 70-80% prolongation up to more than 4 weeks. And I think that could be a remarkable thing for the clinicians for that.
So definitely.
So I want to know that.
Yeah, sure, sir. I think it's a very pertinent question and a common question from all of the doctors available. So the basic thing is that, as per the protocol, the study was up till delivery. So yes. How we did it, that till the time once the preterm pregnancy was delayed and the doctors felt that, okay, after a week, patient can leave the hospital. So that's how the patient left the hospital and continued at their home. And when the delivery was there, they were brought back again to hospital. So, sir, around 67% of patients, they achieved that 30 days increase in their pregnancy, roughly 30 days, you can say.
67%.
67%. It's a very high percentage, sir.
Yeah. That you have not mentioned there.
No, that was my second, third slide, sir. Those bar graphs.
Oh.
Yeah.
Then it's a really a good thing that I think it should write 67 should be converted to 97 in your future.
Means, sir, it depends. Like, some cases are really bad, as you are aware, sir. So in those cases, like, when they are not getting enough time also to shift to hospital, and the cervix is open so much that, like, you can't delay it any further. Though the trip is started, but sometimes it happens. So those cases are very, very few. You see, even in twin pregnancies, out of 13, 12 survived the 48 hours. And beyond 7 days, like, up to 15 days, their age was increased in case of nine cases out of 13.
So you have studied up to 211 cases, no number?
212.
212,
Yeah.
212. And
So this was only
all were sponsored by you, or
Yes,
they
sir.
purchased?
Yeah, this is no. We had provided the medicine.
You had provided that.
This was like DCJ approved protocol.
Study.
And it was registered on CTRI. So as per the ethics committee, recommendation, we had to provide the medicine.
All right. I think the expectation is much, and initial results are really rewarding for that.
Yes,
we
sir.
hope that it should be working well.
That's right, sir. With your blessings, sir, definitely will be succeeding. Thank you so much, sir.
Thank you.
So I think we'll handle the questions at the end, and you can, sir.
If there is any question now, also you can chat.
I don't see, sir, at this moment any questions.
All right, we'll discuss it then.
Yeah.
But however, it's a wonder molecule, and it's a I think monopoly molecule.
Yeah, it is. It is at this moment, sir. Yeah.
So I think all clinicians will request you for the cost cutting and how to reduce that and all that. That's a major thing.
It's a biotechnology product, so definitely, sir, the expense is at this moment very high, and we'll try definitely, sir, to bring it down.
Yeah, that's the thing.
Yeah. Mr. Deb, you can start the presentation.
Yes. We can start?
Yes, sir, please.
Yeah. So I sincerely welcome everybody, all my viewers, my colleagues, my students, my grand students, and busy clinicians, surgeons, for this again continuation of our E-Gurukul program, a Juventus initiative, which is very, very, I love this program because teaching is my passion and all that. I couldn't stop this program even after episode 6. We continued, and this is a episode 9 program on surgical skill transfer and solving the clinical dilemmas. It's mainly targeted for clinicians and for common problems in clinical issues and surgical issues, and solving the dilemmas thereafter. And of course, I share my own personal work in that forum. It may not be the one and all. The surgeons vary, the techniques vary, the methodology changes, it's a dynamic. So I just, with a humility, I can say that I can share. I cannot say that it is a, you follow it's the best and all that, but it is the way in which I do it. That's a thing which I, with all humility, I can say. It's my way of doing it. It may be bad, it may be good, it may be somebody may do much better than me. I expect that the newer generation of surgeons will do much better than me. But I feel that grooming the new generation, and whatever you acquire in the surgical field, you must transfer it to the junior people so that they can do much better than you. With this, I start this episode number 9. And here I again bring always greetings, because I'm all surgeons, all at certain point of time, they believe in destiny, they believe in something supernatural power and all that. And therefore, I need a blessings of this great Lord to all of us and all surgeons, so that when we do this surgery, the healing is with their hands for that. Imagine if we bring an incision and the wound doesn't heal, what would have been a precarious situation of the patient and all that. So healing is not at our end for that, but almost the skill is important. If the skill is good, I think God is going to help on that. So this episode, again a common topic, day in and day out, you must be seeing this particular case in the OPD. and pelvic organ prolapse. So I will be dealing with the surgical procedures, the tips and tricks. But before that, there are a lot of controversies of the pelvic organ prolapse, the understanding of the pelvic organ prolapse, the genesis, and the different uniformity and the confusion and controversies arising out of the different classifications and all that. I will just cover it and brief it, mainly the debates and controversial issues for that, and then focus attention on the surgical procedures, the tips and tricks for that within a couple of hours, 2 hours and 2 hours 15 minutes. Now, the hard facts and pelvic organ prolapse. This entity is well known since time immemorial. Since time immemorial, this is common. And fortunately, the mortality is negligible, but significant morbidity is there. The suffering, the women suffer in silence. Every one of you must have realized that they must be seeing patients at the age of 70, 80 with presidencia for long years, 20 years. They are having, and they suffer in silence. They don't come to the hospital and all that. And suddenly they present to the hospital once there is a bleeding. There is a decubitus ulcer, there is a bleeding. They are apprehensive that there is something inside. They're not, they are really bothered about this discomfort and all that. But they're managing the discomfort. When the bleeding comes, they present with that. Even with the prolapse, they suffer in silence for that. Seen in elderly but distinct entity in nulliparous and reproductive period. Usually we see that these are the gynecological problems in postmenopause. But there is in nulliparous and unmarried girls, they also present with this infertility and all that. We find on nulliparous prolapse for that. And also, we know that the childbirth and pregnancy is one of the factors aggravating the situation, and during the reproductive period also they are presenting with that. This is very, very important. We create the diseases, iatrogenic. I think we create the diseases. That is unfortunate. Post-surgical, post-hysterectomy, either vaginal or abdominal hysterectomy or laparoscopic hysterectomy, these we find the post-surgical prolapse for that. These are mainly, I divide into ill-chosen operation and ill-done operation. Before going for surgery, you have not properly chosen this type of surgery. You have done an incomplete surgery. There was a pre-existing lesion, but you have ignored that. There is a prolapse, but you have done a hysterectomy for that. Automatically, that is there. You have not targeted for the pelvic floor repair for that at the same sitting. There is an ill-done operation. But ill-chosen operation, identification of the hernial sac, like the enterocyl, the pouch of Douglas, you have not identified it properly during the time of surgery for that, ill-chosen. And there could be a cystocyl, but you have done the other procedures for that. So these are some of these ill-chosen operations. Ill-done operation, again, an example, you have not fixed it. You have not given a proper attention on the suspension of the vaginal vault for that. And that is the most unfortunate thing in post-surgical and iatrogenic. Now, pathogenesis is ill understood. We know that there are a lot of things in the pelvic floor, which I will cover about the pelvic floor functions and the supports of the pelvic floor. But there is not a full understanding of the pelvic anatomy for that. Luckily, after the pelvic, the laparoscopic procedure, I remember when I was giving a talk on Silas was presenting with pelvic floor, understanding pelvic floor from above. I told Silas that I will speak on understanding pelvic floor from below. I think if you combine that the authenticity and the results will be much better for that. So understanding the pelvic floor structurally can be understood, but the functional is still not understood till today. The functional part, how it protects, how it absorbs, and which is superior, which is inferior, I think that understanding the pelvic anatomy is still $1 million question for that, and is surrounded by myths. And at last, we know that the basic 3 concepts we know by Delancey: suspension, attachment, and fusion, which I will cover in the next couple of slides. And of course, when we come to the classification and staging, it creates a lot of confusion and controversy since last few decades. Earlier, once upon a time when we were students, it was very simple. Classification was very simple, and now it has become complex. I don't mean that we have created the complexity, but there is a need of changing the classification, because the simple classification lacks many things. So therefore, the classification and enigma and controversy has to be dealt with it, and that will cover that. So the issues, what it means, pelvic floor repair, what it means. I think it's a common thing. It's understandable that when the intravaginal wall, the posterovaginal wall, or the apex descends below, I think that is known as a prolapse. Now the question comes, the normal level. What is the normal level of the cervix? What is the normal level of the vagina? And up till what extent it descends for that also? And what should be the anatomical landmark for that? That has to be found out. So the objective assessment as well as subjective assessment, both has to be taken. And here in the case of pelvic organ prolapse, subjective is more important. You cannot correlate directly with the subjective and objective. The patient has a bulge symptoms. She has a bulge symptoms, and you find that there is a bulge, there is an apical prolapse, there is a cystocele or a rectocele for that. Then correlate with that. Many times you cannot have. Suppose subjective, the patient has a bulge, has on examination you find that there is a cystocele. The patient doesn't have any symptoms. Is a first degree descent is a common thing in paras women, and the cervix is peeping at the introitus. There is a cystocele, but the patient is not feeling anything else for that. So what it means, although it's a subjective assessment of prolapse, does that patient need a treatment? I think pelvic organ prolapse, I think most important, if it is symptoms producing, then treat it. Even if you find that it has descended below the normal landmark level, and there are two landmarks, one is ischial spine and another is a hymen. And at that level, this is there, then we can say if it is causing a problem, even with that, you can diagnose for that. Only exception is that is the case of recurrent UTI. Patient has a moderate cystocele, recurrent UTI, she doesn't have bulge symptoms, but these can be attributed to the cystocele. If there is again a post-void residual urine is more, I think you can do the surgery for that. Otherwise, surgery, say no to surgery in that particular case. So this is important what it means. Factors responsible, there are activating factors and aggravating factors. Supports of pelvic organ, I will touch a little about the supports, understanding of the supports, then the classification systems. There is a lot of controversy. I think I will take little more time on the classification systems and what is the latest classification system of understanding. This POP-Q classification is really confusing for that, and I must explain, devote some time for that. And of course, what are the preventive steps? What is the rational treatment? The main objective of a surgical skill transfer, rational treatment, and view of my videos, surgical videos, and the different aspects I will cover. And lastly, the controversies and consensus versus consensus. Now, the factors responsible, activating factors and aggravating factors. Activating factors, the main thing is inherent weakness in supports of the uterus. This is a thing which cannot be assessed. There is no measure to assess the weakness and the supports of the uterus, but inherent weakness in supports of the uterus. Why? Because all paras women doesn't have a prolapse, all post-menopause doesn't have a prolapse, even nulliparous has a prolapse, and even without anything rapid succession of multiparity do not have a prolapse for that also. So the major thing which attribute that inherent weakness in supports of the cases which have an inherent from the beginning, from the birth, they have an inherent weakness in supports of the uterus, and any other factors like pregnancy and childbirth trauma, menopause or post-menopause of estrogen deficiency, or post-surgical iatrogenic not proper fixation with the Meccan rod and the cardinal ligament and the uterosacral with the angle of the vault. I think this could be an activating factors for that also. And aggravating factors, we have read many things like chronic cough, intra-abdominal pathology, and all the factors for that. But the main thing is ultimately, I believe that debility and asthenic conditions. These are all important. Debility and asthenic conditions are mainly responsible rather than the other things. Now, coming to the pelvic organ, the supports. What are the supports in pelvic organ system? We have a ligamentary support. Initially, when we were students, I think much importance was given to the round ligament and the broad ligament. Now, these are redundant. Now, the pericervical ring of ligament across, that is important now. The cardinal ligament, the transverse cervical ligament, the Meccan-Rods ligament in the lateral part, the pubocervical ligament in the anteriorly, and the uterosacral ligament and the posteriorly. These are attributable to a really affected, really a very good support system for the cervix as well as the upper vagina for that. That is beyond doubt. When we did this surgery also, we can definitely found if the uterosacral you cut it and Meccan rod you cut it, the uterus descends for that. So ligamentary support, these are condensation of the endopelvic fossa and pericervical, and initial originates from the lateral margin and 2 centimeter they are common, then they bifurcate, then they go in the 3 different directions, laterally, anteriorly and posteriorly, and these are all triradiate ligament. These are very, very important supports of the uterus. Fascial, see endopelvic fossa. When we dissect it, endopelvic fossa can be seen. The endopelvic fossa is condensed into ligament in some, but the rest of the cases, the fossa spreads out over the levator ani and spreads out anteriorly in the pubocervical fossa, posteriorly in the rectovaginal fossa and the fossa of the non-velar. And these also contribute a great deal, particularly the vaginal walls. The muscular, the muscular layer, like in the levator ani, the 3 levator ani, the pubococcygeus, iliococcygeus, and the ischiococcygous. We know the classical urogenital diaphragm, and these are the cases where the muscles doesn't protect directly to the supports of the uterus and vagina, but when the fascial support and ligamentary support are weak, there is a tendency, and when the urogenital hiatus is more, there is again an aggravation of the prolapse for that. So this contributes to the muscle, and the tone of the muscles is also important for that also. So these are all contributing factors. And of course, the last thing, the biochemical factors, the hormones. In menopause, post-menopause, the first degree prolapse which is there inside the vagina, I think post-menopause it comes out as a presidencia for that. And these are attributable, the hormones, the estrogen mainly, are responsible for increasing the tone of the muscles, the tone of the fossa, the tone of the ligaments for that also. So these are all important hormones, and that's why the menopausal and postmenopausal are more prone to develop the pelvic organ prolapse. Now, there are levels of supports at all levels. We know that there is a 3-tier system. We know the different endopelvic fossa. We know the ligaments. We know the muscles, everything endopelvic fossa, condensation, and the vaginal wall. We know that the musculofibral layer below the lamina propria and in between the adventitia, this layer forms the very important condensation fusion to the nearby structures for that. But Delancey has clearly categorized into 3-tier system, which is very, very convincing and logical. The upper part is a suspension by the ligaments, which I have already told. The ligaments, the cardinal ligaments, the uterosacral and the pubocervical ligament is a suspension. The middle part of the vagina is attachment, the endopelvic fossa, the pubocervical fossa and rectovaginal fossa, attachment to the nearby structures or over the muscles and the lateral pelvic wall. And lower part is the perineal body. The perineal body is the fusion. It fuses with the perineal body and the transverse perineum, either superficial or deep with the bulbocavernosus. And these are responsible for giving a support at these 3 levels in the vagina, lower vagina, middle vagina, and upper vagina, and the cervix, and giving a different support, a Delancey support, which is very, very logical and convincing. Now, the most confusing term is the classification systems. The older systems is the anatomic sites, depending on the anatomic sites, and older system, the site of the end, there is the hymen is the main thing. Hymen is the main thing. Below, above the hymen, at the hymen, below the hymen, and completely outside of the hymen and all. And staging is again a subjective, it's not objective, mild, moderate, and severe. It's a subjective thing. This was there for long years. There is no quantification also. But this has a strength, this has a weakness. Strength. What is the strength of this older system of classification? It's easy to define. It's easy to define, not complicated. But weaknesses, this is subjective. Interpersonal variation. What is mild to me may be moderate to somebody else. Mild cystocele. Some may see that it's a moderate cystocele. There is no quantification in that. Lack of anatomic defects. Lack of quantification. These are the main weakness of this classification system, older system. So there is a need for a change in the system and newer system for that. So these are traditional anatomic site prolapse classification. Old-wise, we say that anterior vaginal wall prolapse, if the lower part prolapses, there is a urethrocoele. Upper part prolapses, it's a cystocele. And apical segment uterovaginal prolapse, the cervix or the vault, this is central. And posteriorly, upper part posterior-vaginal wall is enterocele, is the posterior upper, middle part is the rectocele, and lower part is the deficit perineum. So these are basically the different classification system and all that. But basically, again, I have to emphasize that while dealing with the pelvic organ prolapse, three different aspects has to be dealt with: anterior vaginal wall, posterior vaginal wall, and apical. And there could be a combination of everything also. When the apex comes, apical prolapse occurs, it drags the vaginal wall along with that also. But if isolated vaginal wall prolapse like isolated rectocele or isolated cystocele can occur without a coexisting apical descent for that also. Now these are the anatomical intravaginal, as I have already told: cystocele, urethrocoele, enterocele, uterovaginal prolapse, vaginal wall prolapse if the uterus is absent, and postovaginal prolapse, enterocele, rectocele, and a deficit perineum for that. So when we see the classification stages, age-old concept, the SOS classification, when we were students, we were reading the SOS classification. SOS classification was of 4 types: first degree, second degree, third degree, and fourth degree. And that is depicted to only apical prolapse. It is not for the vaginal wall prolapse. It is apical or central part, first degree, when the cervix is below the level of the ischial spine. It comes in the vagina, but normal level is at the level of the ischial spine. When the portio is below the level of the ischial spine, is the first degree. If it is up to the level of the introitus, is second degree. Up to the level of the introitus, second degree. Just outside the level of the introitus is third degree. And whole uterus is outside the level of the introitus. You get above the swelling, the fundus, you can palpate it, then it's a fourth degree or precedentia. These were described. Malpass corrected that yes, there should not be 4 degrees, there should be first degree, second degree, and third degree. Third degree is precedentia. First degree is just below the level of the ischial spine and inside the vagina. Second degree, cervix outside the hymen. And third degree, whole uterus outside the hymen. This is a very simplified definition of a Malpass classification, age-old concept. It is understandable for apical and central defects, but it is not understandable for the anterior or posterior. And it's not site-specific. It is not a site-specific. It's lacking. Anatomical landmark here are 2 ischial spines and hymen. Normal station is at the level of the ischial spine. When it comes at the level of the hymen, it is a first degree. It is outside the level of the hymen, second degree. Whole uterus outside the level of the hymen is third degree. Now, the update classification next comes as a Baden-Walker halfway system. It is almost same as the Malpass classification, and the POP-Q classification is the latest system for that. Baden-Walker, what is the change? It's user-friendly, easy to record, maximizes the amount of detail that can be recorded in a brief space. It lacks site-specific defect. It lacks quantification. It's again on a central defect for that also. And there are 6 defined sites in vagina. Same thing. It's just a different name, Baden-Walker halfway system. I think urethral vesicle is anterior, uterine cul-de-sac is superior, and posterior rectal and perineal is posterior. Extent of prolapse is 0 to 4. And reference points here is again same, ischial spine and hymen. Perineum graded to difficulty as perineal tears. Strength of levator ani is included under the Baden-Walker. Strength of levator ani contractions. I think the tone of the levator ani is approximately from 0 to 4. They use it with the manual thing, the tone supplemented with some gadgets for that. And this is the same Baden-Walker halfway system for that. And it's almost same, just a gradation of 0 to 4, 0, minus 1, and 2, 3. These are the Baden-Walker. Now comes, because it lacks quantification and it doesn't have a site-specific lesion and it limited to the apical descent, the POP-Q classification came into force. This is the genesis of POP-Q classification. There is a need and the system classification system. But it is very confusing, and therefore I must devote some time to clarify some of these issues. Once you understand it, I think it's very easy. So this was the evolution. This is the standardization of terminology. The 3 different societies agreed for that, and the International Continence Society, American Urogynecological Society, and Society of Gynecological Surgeons. These combiningly, they found that this standardized the terminology and agreed upon the POP-Q classification. And basing on that, the need for quantification was there, need for site-specific was there, need for objective assessment, not subjective, better communication and understandable, and measurements. The most important thing is that you can measure rather than arbitrarily say that it's a mild, moderate, and severe. So why? Quantification of prolapse. Compare outcome of surgical repair. If you have repaired it, if you can compare it, if when there is a measurement, inter-individual reliability should be there. It's not a different thing, mild versus moderate. Standards in written publication, scientific. So when we give for a research purpose also, This adds a great deal for that. The strength. What is the strength? The strength is more scientific and more reproducible. But weakness of this is that it appears more complex. The understanding this is more complex, and it takes more time to level and classify the stage for that. Even if you are acquainted, even if you can understand it also, if you plot it in graph and measure it, it takes more time rather than just abruptly telling that it's just 1, 2, 3. So easy to understand, difficult to practice, or difficult to understand, easy to practice for that. So in PopQ systems, there are 3 reference points. There are 2 reference points, 6 reference points, and measurements are 2, and 3 distinct measurements, and you put it in grid system of presentation. So reference points, 2 in the anterior wall, 2 in the posterior wall, 2 in the apical. 2 in the anterior wall designated as AA and BA. I will tell what is AA and BA. 2 in the posterior wall, AP and BP. And 2 apical, C is cervix, D is pouch of Douglas. If cervix is not there. And measurements are in form of a minus or plus. Negative proximal to hymen is minus, distal to hymen is plus. And 3 distinct measurements: genital hiatus, then perineal body, and total vaginal length. And it presented with the grid system of presentation complemented with the line diagram. We have a line diagram along with the grid system so that you can really quantify and understandable for that. So measurements are in form of a centimeters. Hymen fixed point of reference. Plane of hymen is referred to as 0. Above is a negative number. Below is a positive number for that. Now these are 6 points: AA, BA, AP, BP, and in the apex C and D. These are the 6 reference points for that. And what is A, B, A, C, and D? I will just tell you. And GH, genital hiatus, perineal body, total vaginal length. What are the measurements? I will just repeat it. What is point A? Point A is anatomically defined. It is midline of anterior and posterior vaginal walls. In the midline, in the anterior and posterior vaginal wall, A, point A, AA or AP. I think these are the case. So 3 centimeter proximal to the external urethral meatus is point A. Urethra or hymen is point A, 3 centimeter proximal. It is a fixed measurement. The range of position is -3 to +3. If it comes 2 centimeter, then it comes the -2 or -1 or +1, +2, and +3. So 3 cm below the hymen is plus, above the hymen is minus for that. But this is a fixed point, point 1. So AA and AP posteriorly is a midline anterior vaginal wall 3 centimeter above external urethral meatus, approximate location of urethral vaginal junction, and midline posterior vaginal wall 3 centimeter. The same AA and AP are all same 3 centimeter from the proximal to the hymen or external urethral meatus. Anterior wall is AA, posterior wall is AP, and this is fixed. What is a point B? Point B is not fixed as point A. It is a variable and it's a dynamic. What is a point B? Most distal position of any upper vaginal wall between the anterior and posterior fornix or cuff and point A. I think this is important. If there is no distal protrusion, point A and point B are in the same plane, 3 centimeter proximal to the hymen. If any bulge occurs above the point A up till the fornix, and that is a dynamic that changes from one place to other, that is the point B, and value of again -3 to +3 is at point B. Remember, so B, BA and BP are dynamic or variable points. It's the most distal point of any part of it. If there is a bulge in the anterior vaginal wall or a posterior vaginal wall above the point A and it falls behind, it is a point B, which is designated as a dynamic change point for that. Now, if you correlate with the line diagram for that, this is the midline. Midline is the hymen, and when the C comes, C is at the level of the cervix, is at the level of the hymen, and when we find that posteriorly the AP, posterior vaginal wall, the AP is there, BP, the posterior vaginal wall again, the point posteriorly B is below the A, so there is a bulge in between. Cervix has dragged out for that. And the BP and AP, I think BP has only fall, C has come, but AP is there in the 0.3, is a -3. So in the posteriorly there is nothing, but anteriorly you find the anteriorly vaginal wall prolapse, AA has come down to +3, whereas BA has come down to +6. So this is mainly a predominance of the anterior vaginal wall prolapse with the apical descent cervix at the level of the hymen, and there is a little deviation from the, instead of AP at -3 and BP at -3, BP has descended to 1 centimeter below -2. So this is reflecting the line diagram in particular. So difference between A and B. A is a fixed point 3 centimeter apart from the hymen, but B is most descending part of the compartment, both anterior as well as posterior. So point A and B are completely different for that. BP and BA are dynamic, whereas AA and AP are AP is the dynamic, and this comes down as a bulge for that. This is not a static thing. What is a genital hiatus? Genital hiatus is the middle of external urethral meatus to the posterior hymen. Middle of external urethral meatus to the posterior hymen is genital hiatus, and cervix, C is cervix, most distal edge of the cervix, the leading edge of the vaginal cuff after hysterectomy is D, is Douglas, posterior fornix, pouch of Douglas, and no cervix, so that D is point when there is a post-hysterectomy thing. And perineal body is posterior margin of the genital hiatus to the mid-anal opening for that. So perineal body for that. Now, TVL is the greatest depth of the vagina in centimeters. C and D in the normal position measurement without straining has to be taken, and that gives rise to the total vaginal length for that. So, after all this understanding, we come to the stages of pelvic organ prolapse, staging of the vaginal prolapse, pelvic organ prolapse. Stage 0, there is no prolapse. So AA, BA, AP, and BP are all at -3. Remember that. Normally, it is at that level for that. And C or D and between TVL and less than TVL is at least 2 centimeter deviation is there. Stage 1, most distal portion is more than 1 centimeter above the level of the hymen. More than 1 centimeter above the level of the hymen. So if there is a descent, more than 1 centimeter. Stage 2, less than 1 centimeter proximal to or distal to the plane of the hymen. So is stage 2. Stage 3, more than 1 centimeter below the plane of the hymen. It comes to below the plane of the hymen. Plane of the hymen is stage 3. And stage 4, complete eversion. Distal portion at least more than that. The TVL is -2 centimeter. So physical examination technique, the protrusion of vaginal wall during straining, traction causes no further descent, subject confirms the size of the prolapse, straining examination confirms full extent of the prolapse. So this is the grid that A, B, and C in the first 3, genital hiatus, perineal body, and TVL in this middle, and AP, BP, and D in the posterior compartment. This can be correlated with the line diagram. So physical examination technique, position of the subject, type of vaginal specula, straining or coughing, bladder empty, method of quantitative measurements, all are taken into account while quantifying all this. So again, the POPQ system, I am again focusing. A and AP are fixed point 3 centimeter proximal to the hymen. BA and BP, both in anterior and vaginal wall, this distance, they are mobile, they are dynamic, and any protrusion from that will be accounted in terms of minus or plus for that. And C is cervix, D is pouch of Douglas. And of course, genital hiatus, perineal body, and TVL, we have already explained that. So if you combine the POPQ class with the grid system, the gridding system, the grid is on the below and the line diagram is above. You can easily correlate with the line diagram here. Now here what is happening? The C is at the level of the cervix. AA and BA are absolutely in a normal thing, but BP and AP has come below the level of the hymen, and this is see that yes, it has come. AP has come up to +2, BP has come up to +5, and rest everything is the normal thing. Just a cervix descent up to -6. So this is a case where example where there is a posterior vaginal wall prolapse along with the rectocele and enterocele could be there. So standardization and uniformity of classification is necessary. Staging is important for appropriate surgical technique. Should be simple, user-friendly, and reproducible. It takes a little more time. It takes a time for deviation of all these and putting it in grid as well as in the line diagram for that. And that's why it's very, but once you understand the quantification system is very, very easy. And it's more objective rather than subjective. And it's an estimate rather than guesstimate. The previous thing is guesswork or a guesstimate. Now, if you use this is an estimate for that. Now, then the other aspects of the pelvic organ prolapse. After classification system controversy, we accept the POP2 classification and standardization. What are the advantages of this estimate? Measurements could be done and site specific and the strength. These are the particular strength, and the quantification is absolutely possible for that. It is not only limited to the apical segment. It is all anterior wall, posterior wall, apical, all are incorporated here. That's the main fact for that. Earlier, we are limited to only cervical or apical descent for that. Now, next part is the preventive steps. Can we prevent prolapse? The pregnancy and childbirth. I think this is a very important part for that. And studies have shown that when we do a cesarean section, is going to reduce the incidence of prolapse, remarkably reduce the incidence of prolapse, if not zero. Many cases of post-cesarean do have a prolapse also, but at least it can reduce to a considerable extent pregnancy, the prolapse, if you go for a cesarean section. But it's not to reduce the prolapse, you don't go for elective cesarean in all cases. That's not that's a bias only. So pregnancy and childbirth, the multiparity, the rapid succession of pregnancy, labor management is important. A lot of things have we have been taught in our undergraduate as well as postgraduate regarding the factors, aggravating factors or activating factors in pregnancy. But the main theme in labor management is the stretching, is the duration of labor and stretching of the pelvic floor. More amount of stretching is there, more amount of damage is there for that. So duration of labor is important, and undue stretching of these tissues is important. Large macrosomic baby, all these are important. Along with that, little part is contributed to your instrumental delivery. But remember, the instrumental delivery, cut-shutting the duration of labor also can prevent the prolapse for that also. But main thing in labor management is the duration of labor and stretching for that. And second is adequate rehabilitation. So therefore, rapid succession of pregnancy now in a small family norm, somehow it is not there, but rehab, nutrition, all these maternal nutrition, all should be effective for that. And of course, the pelvic floor exercise. Now the yoga has become a part and parcel of every human being nowadays. Oh, more of emphasis about physical fitness and all that, and therefore fitness for the pelvic floor. Why? If a fitness for your hands, for your legs, for your body, why not? Why you are ignoring our pelvic floor? I think pelvic floor exercise has to be done for that also, and that's a physiotherapy, and particularly in post delivery. I think this is very, very important pelvic floor exercise, which is really contributing to increasing the tone of the muscles, fascia, and the ligaments for that also. And of course, appropriate management of menopause and post-menopause management. Menopause, post-menopause management. The hormones, we know the role of hormones, the estrogen in the tone of the muscles. I think making feminine forever and all that, I'm not proposing that, but at least the menopause and post-menopause management in relation to the appropriate nutrition and other things are most important to prevent prolapse. Now, preventive steps again, surgical. The main thing nowadays in a small family norm nowadays, we are not going for multiparity and all that, a small family norm. These surgical steps are important. More and more cases nowadays we see in post-surgical, post-hysterectomy. I think these how we can prevent it. I think this can be majority of the cases can be prevented. Recognition of pathology and tackling simultaneously. As I have already told, the pre-existing lesion, pre-existing thing inside the before the surgery, a small, you find a significant enterocyl, or you find a significant intravaginal wall prolapse with cystocele, you ignore that and do a hysterectomy, and subsequently you find that there is a pathology which is there. And if it's there, it's do a complete surgery, don't do an incomplete surgery. I think you tackle all these procedures at the same time. Apart from it, the apical suspension, very, very important. Even if you do a vaginal hysterectomy or an abdominal hysterectomy or a lap hysterectomy, the angle of the vault should be adequately sutured to the uterosacral ligament. That is considered as one of the best support for that. Uterosacral macronodes, I think this is there. And while doing the vaginal hysterectomy, particularly in non-descent, earlier it was a circular incision all throughout. Now we recommend don't give a circular incision. Anteriorly and posteriorly, leave the attachment in the lateral part so that the vaginal wall will be attached to the macronodes and uterosacral in the lateral part, which preserves that. And in addition, you give an angular supporting or a Mackel's scaldoplasty for that also to prevent that. So angle of the wall to our uterosacral canal is absolutely important wherever you do a vaginal, abdominal or laparoscopy also. That you cannot be ignored for that. And that is a very important step in preventing the post-hysterectomy prolapse. And of course, there are Mackel's scaldoplasty in routinely all cases, external Mackel's, internal Mackel's, we all that. And if you just stitch with the uterosacral, many people, they also do the Mackel's in the cul-de-sac, they close the internal Mackel's also with the non-absorbable suture. For there are merits and demerits and all that we'll discuss with the debates. Sacrospinous fixation. Sacrospinous fixation is a very good thing for preventing recurrence, but do all the cases require a sacrospinous fixation? There is a controversy about it also. I will just clarify that all cases do not require a sacrospinous fixation for that. Uterosacral suspension, of course, uterosacral suspension, not to the apex and all that, but uterosacral is a major thing which has to be suspected, which has to be fixed to the prolapse for the vaginal wall for that. That's easier for that. And we use that. Now, coming to the treatment, there are some treatment. You should know where not to operate. I always tell, it takes 5 years to learn and do the surgery, but it takes 25 years to learn and not to do the surgery. Symptoms and signs. Patient, here is one case where the patients will say symptoms. If the patient will say that, yes, I need a surgery, then you do it. If you detect that there is some abnormality, don't do it. So many cases, they are having a first degree descent, patient is comfortable. Why to do a surgery for that? So these doesn't require any surgery. That is the rule. That is the rule, and that is the basis, and that is the rationality. And something about non-surgical. Non-surgical pessaries, lot of pessaries, ring pessary, and different modifications of the pessary, gallon pessary. All these pessaries are used for that also. And these pessaries also have some demerits in creating the ulcer, in creating the infections, the self-made, self-used pessary, change, hygiene, pessary hygiene, all these are there. And pessaries are absolutely, there are some special situations where pessary is indicated for a temporary purpose for that. Say the brightest example is pregnancy and lactation. I think these are the cases where pessary, but this cannot be an alternative solution to the surgical aspect, pessaries. And pessaries are only in pregnancy, lactation, or those who cannot go for surgery because of some reasons. Now that reasons have declined due to the advances in the anesthesia, due to the advances in the surgical skill and all that. But if the patient doesn't want, this could be an option for them. Now, vaginal aesthetic procedures have developed. I'm just starting the procedure with the vaginal aesthetic procedures of laser in vaginal. I think these are the cases many people are just, it is in a transient phase, it's in the experimental phase. Maybe that the generation now, it has started with the stress incontinence thing and vaginal rejuvenation. I think vaginal rejuvenation they are giving for a laser, and these could be a future for that also. But a case of presidencia cannot be treated with the vaginal aesthetic procedures for that also. Still, that needs a surgery for that. But this has some role in a small, I think, mild degree of prolapse, say a minimal prolapse, first degree prolapse with the bulge symptoms, patient is symptomatic, and you don't do a surgery. I think there you can do the alternative is pelvic floor exercise or vaginal aesthetic procedures for that. So physiotherapy and vaginal aesthetic procedures could be non-surgical. And of course, the main thing is a surgical procedures. What are the different types of surgery? I will just enucleate surgical concept. When we come to the pelvic organ prolapse surgical aspect, the tips and tricks, these are the three important things which I tell in all surgeries. Selecting the right patient for the operation. You have to select the right patient for the surgery, which I have discussed about the cases in detail, which are the cases you operate, and you say no to some cases where they don't require surgery. Then second, selecting the right operation for the patient. There are various modalities of surgery, and you select which operation is best suited for that particular patient, individualized. That's important. And performing the operation correctly, the skill development is important for that, surgical skill. And of course, post-op care you ignore. Do the surgery, forget it. So that should be there. During surgery, do in a surgery in such a manner that you are not required to do a post-operative round for that also. So the best post-op care is a good piece of surgery and the development of skill. And here in gynecological surgery, in comparison to the general surgeons, we are different. We are different in the sense that a pelvic surgeon must have a knowledge and understanding of physiology of reproductive organs, pathology, and clinical manifestations of pelvic disease, and dynamics of psychosocial and sexual development. So these are important when we are designated as a pelvic surgeon or a gynecological surgeon. What are the goals of surgical goals? What are the goals before us? Goals before surgery. You think, restore. Am I be able to restore the anatomy as far as possible? Almost around complete restoration of anatomy. Second, maximizing the function. Third, addressing the urinary and defecating problems. Fourth, promoting the fertility potential if she is keen for conception. But the fertility potential is not affecting the fertility. Minimizing complications and preventing. All these are goals before us for doing a surgery. Way back in 1966, still in the great surgeon, the authority of operative gynecology, he has remarked, quoted, the judgment as to surgical correction should depend upon a correlation of the history and physical findings. Even marked prolapse in the absence of complaint should rarely be corrected. The patient should ask the gynecologist for relief. The gynecologist should not urge the patient to have a corrective surgery if she doesn't feel sufficiently uncomfortable to request it. I think this is the truth. This is the real truth of every surgeon for that. And I remember today my professor in surgery during my undergraduate career. He once told in one of the lecture that boys and girls, if at all in future you want to become a surgeon, don't operate any case unless the patient begs for it. And underlying the word beg, begging and begging. If the patient begging for surgery, then operate. Don't go and operate of your own for that. And still it holds good. I remember that this is very, very important, more so in the medical legal era. Now, principles of surgical modalities. What are the rationale pre-op evaluation? As commonly, this is a major surgery, suppose you are doing it, as per all surgical procedures, the hematocrit value, you must do it, the liver function or the urinary renal function test or cardiological evaluation, everything you do it, and HbA1c, HIV, blood group, everything routinely. I'm not going for that. But what are the specific rationale pre-op evaluation in the case of pelvic organ prolapse? You do it is depending on the present. Suppose he is having a cystosil, you must do a urine and culture. If there is more symptoms of UTI, then do a urine and culture is specifically additional thing for that. Do a pap smear. Majority of the cases they present with an ulcer. This ulcer, you think that is a decubitus ulcer, but this could be malignant. I think these are the cases. And they see when the decubitus ulcer, you repose it and it doesn't heal by 7 days. Think of malignancy, think of tuberculosis. I think these are the clear indications for that. Within 7 days, atrophic ulcer, decubitus ulcer must heal and resolve for that. So rational preparation, pre-op evaluation. If there is the ulcer, do a pap smear. A cytology is a must for that before contemplating a surgery for that. So, and urine culture is a special investigations. Your renal function test, because in a presidentia, long-standing presidentia, because of the back pressure of the ureter, hydronephrosis, all these would damage the kidney for that. So these are all important in addition to the normal evaluation of cardiological and other blood parameters. Then second is understanding the inherent factor. What is the factor? You understand that whether it's going to be a recurrent prolapse from the beginning. Is there any aggravating factors like a chronic cough and all that, inherent factor? Correct understanding of pelvic supports. This is important, and that's why I will elaborate it and spend little time on the pelvic supports and more specifically the ligamentary supports and all that. Critical interpretation of altered anatomy, that is the purpose of POPQ, site-specific quantification system, effect and functional aspect. What is the effect? And planning for the rational modality, avoiding dogmas, individualized approach depending on the problem. You individually select it and plan it, and surgical planning is important. So surgical planning, you do it before contemplating any surgery. It's not that mechanically you operate the same procedure for that. Every individualized case you study and develop your own skill and technique. And surgical craftsmanship is one aspect, developing your skill and technique. So I always say decision and dissection. Both are important to convert you from operators to surgeons. If you want to become a surgeon rather than operator, you build up your skill and technique, and in addition have development, the decision making and all that, what to do and what not to do. Now, surgical procedure in pelvic organ prolapse are broadly divided into restorative, compensatory, and obliterative. Restorative, what is the restoration of the pelvic organ change? What is the change? There is a change, you must replicate and make it normal. And restorative, and using autologous tissues, using endogenous support structure. Endogenous support structure is a restorative. Compensatory, when you find that the endogenous support structure is loose or lax, the tone is less, or there is a recurrent prolapse, I think these are the cases attempt to replace the deficit support by some graft. So autologous versus graft and or mesh is there for that. If only those cases the mesh is there. But now I will just devote little time for the mesh controversy. Mesh is also a mesh, and personally from the beginning also I am not a promoter of mesh. I usually predicted long back and discussed with various big people who are regularly doing mesh and all that. I have in my mind that autologous is still best for that, except in some cases. Rarely there is a case where mesh is required. Otherwise, mesh plasty in vaginal prolapse, pelvic organ prolapse is really a debatable issue. Almost it has resolved. Mesh is a mesh. All authorities have told that mesh is creating more of a problem for that. So autologous is important for that. And third is obliterative, again, closing the vagina. Liffords, when we were undergraduate student, we were reading Liffords operation, obliterative procedure for that also. And now in most of the European countries also, obliterative procedures have gone into oblivion. Now it has again come back. In last AISOG, there was a lot of controversy about this obliterative Liffords surgery for that. Is there a place for Liffords surgery in the present context? Then there is a big debate on that. Liffords, particularly, I always say that Liffords is the original concept of the obliterative procedure is the frail patient, unsuitable for surgery, unsuitable for anesthesia, and these are the cases Liffords. At that time, it was appropriate. Now you find out whether the patient, now technology has evolved, the unfit patient for anesthesia has come down, unfit patient for surgery has come down, the skill has increased. So you can do the same procedure. Why to do the obliterative procedure for that? So this is one aspect where and of course, in some of the recurrent prolapses, obliterative is recommended, and now the little evidence is growing in favor of obliterative in some of the European countries and all that. But personally, if you ask me with all humility, I don't have any experience on the obliterative procedure for that also. Now the surgical consensus is compartmental surgical approach. See, you divide whether it's the anterior, posterior vaginal wall, anterovaginal wall, or apical, or a combination. Identification of the defect, identify the defect, and of course, tissue loss, very important. The promoters of the graft or the promoters of the mesh, the main target was that while doing an autologous repair, you are losing the tissues. Tissue loss is there. You are excising the vagina, and therefore, functioning part is gradually diminished. But there is a limit to it also. You can assess it. You have a plastic sense up to which limit you can excise the tissue, restoring the functions also. I'm not in favor of completely sticking to the idea that you don't remove the vaginal mucosa for that. Whatever desired, it is removed. There is no problem for that also. But at the same time, the functional capacity of the vagina could be restored for that. And of course, hemostasis. Gone are the days where vaginal surgeons were thought to be bloody surgeons for that. It's not a bloody surgeons in the previous thing. You don't designate us as a bloody surgeons, and hemostasis is now there at all level. You can use hydrodissection, you can use the infiltrate the vasopressin, you can infiltrate the adrenaline dilution, or you can use the bipolar force for that. And hemostasis is recognizing your surgical limit. That's a very important thing. Up to which limit you do it. And of course, over and above everything, vaginal surgery needs a plastic sense. Abdominal surgery, you can do whatever is there. All surgery needs a plastic sense, I believe. But vaginal surgery is a so delicate organ. Sexual function is important, and therefore it should be a plastic sense, pure plastic sense. All gynecologists should have it. And minimal invasion with maximal benefit, you must have it. Now, in the vaginal approach, the anterior vaginal wall repair, the paravaginal, this is a rarely we find, very rarely we find, majority of the cases are central, but paravaginal is there, arcus tendinous, there is a separation in some cases, but routinely this is not a very common situation in paravaginal, but still, if there is a paravaginal, you must give attention to the arcus tendinous repair for that. Posterior vaginal approach, apical or ancillary procedures, you can do it ancillary procedures for that. Now, abdominal approach. Abdominal approach in a case of prolapse. I think these are the cases where prolapse basically genital, I think pelvic organ prolapse, primarily it should be targeted vaginally. That's my belief and all. Primarily is a vaginal approach for that also. You can restore the functional anatomy as well as the structural anatomy much better by vaginal route also. But there are some exceptions in abdominal approach. I can say that abdominal sacrocolpopexy and cervicopexy, abdominal cervicopexy, nulliparous prolapse, and abdominal sacrocolpopexy in a vault prolapse and recurrent prolapse, more commonly recurrent prolapse. These are the two which is acceptable to me. It's my feeling and all that. I cannot say that it's absolutely a rule, but I believe that abdominal sacrocolpopexy and abdominal cervicopexy, these are all abdominal root canal. The cervicopexy again with autologous tissue of erectus sheath or with the mesh, that's an option for that. Abdominal sacrocolpopexy is always with the mesh in a case of vault prolapse, and that is acceptable for that. But that mesh remains in the peritoneum extravertebroperitoneal, that is not in the vagina for that also. Only suture is anchored it into the vagina in the vault, in the cuff, and cervicopexy again is the posterior part in the fix into the uterus cervix and fixed to the sacrum for that. So this is somewhat acceptable for that. Otherwise, abdominally is very difficult and it's not a suitable method. Only thing abdominally long back we see. Suppose there is a cystocele, small cystocele, and there is an anterovaginal wall prolapse. You are doing an abdominal hysterectomy or a laparoscopic hysterectomy. The additional step you can do it, one step, which I get a benefit on. You dissect the anterovaginal wall little more, about 4-5 centimeter of the vaginal wall, bladder separation little more, and take the wedge of the vagina in the central part. If you take the wedge of the vagina, excise the wedge of the vagina, and suture it, the vault at that age, I think that's going to do some benefit to the cystocele repair for that. That is one exception to that. It's an adjunct procedure. It's not a pure procedure. Knowing fully well that is you don't go for that. Vaginal is always best for that. So abdominally, same thing. These two procedures can be done by laparoscopy also, and these are there is some thing either we can taker or with the suture. You can do it also with that, and that is acceptable for that. So laparoscopic approach, adequate training is there, equipment and setup should be there. The mesh, sutures, takers, that should be there. But laparoscopic approach for all, I think hysterocolpopexy and all that, and repair of the paravaginal prolapse for that also. That is experimental, still experimental, and waiting for the results, and the complications are much more, and balancing the efficacy as well as the complications. I think that's needs a long way to go for that also. But these are the basic thing. Fundamental thing is that the vaginal approach is the best way for the genital prolapse. Now, when we come to the ideal graft, mesh is a mess. Mesh is a become a mess. Now it's ideal graft. There is a macroporous. There are different types of mesh, 5 different grades of mesh. Non-antigenic, exhibit low infection rate, decrease recurrence of anatomic defects, cause no harm with respect to bowel and renal function, relatively inexpensive, cross the boundary of controversies and debate for that. And therefore, this is really in a form of a mess. Even if it is not eroded to the vagina, it can erode to the bowel if it is there also. So there is a little question mark. There is a little doubt if you compare with the autologous graft for that. But a recurrent prolapse where the inherent tissue, endogenous tissue is weak, I think there is no option you can do that. Otherwise, routinely, I don't recommend this type of procedure from the beginning also. When people are doing a peri-G, APG and all that, a lot of people told that why are not. I told that I don't see the future of it. Now after that, those people tell that no, you have predicted long back, about 15 years back, that this mess, now we have found the mess is a mess. Of course, everything has a solution for that. Now, suppose after observation mesh is a mess, maybe that a new mesh will come, biological mesh will come, and good mesh will come, which can tackle the problem and solve the problem and eliminate the complications and all that. Then we'll accept that. Everything is it's not a fixed rule. There is a change, there is a change dynamic, it's a changing. Researchers will find out newer devices and all that, and we are open to everything for that. Same the vaginal obliteratory procedures, I think these are the cases which I have already hinted. Surgically frail candidates, recurrence, expected short life expectancy, limited activity. Now, here I will tell, surgically frail candidates. Who are the surgically frail candidates? It's easier to tell, frail candidates, whether you declare that she is frail or she tells that I am not going for a surgery. It is a very different question. Recurrence, yes. If it is a recurrence, you can use the compensatory, the graft and all that for that, a recurrence. And obliteratory procedure is another indication for that you can do a recurrence. Third is expected short life expectancy. You are not God to know that your life is this much. You cannot say that the patient age is 90 years and that's why she has a short life expectancy and I will do this procedure. She may be living for another 20 years. She may be living for another 10 years. 10 years is a long time for that. So this I don't accept it. Expected short life expectancy. You don't expect. Even you don't have a control over your length of life. You have a control over your breadth and width of life. That you mentioned. And limited activity. Now, very old people have a limited. They are very active for that also. They're active till the last breath. And I always believe and always preach that be active till your last breath. Don't stop it. You retire, you rest, means you are gone. So active till your last breath. Maybe professional activities, maybe non-professional activities, whatever you do it, be active till the last breath. Now surgical controversies again. Route, vaginal route, preferable. Number 1. Laparoscopy and abdominal, in very, very rare situations, I will say that this is the case for that. Mesh versus autologous tissues. Autologous tissues is one of the best in comparison. The mesh in the present situation of mesh controversy, maybe that in subsequently it comes. Suture materials, absorbable versus non-absorbable. When absorbable catgut was there compared, now good delayed absorbable suture are there comparable to the non-absorbable. So non-absorbable suture has got some demerits for that also. So therefore, in appropriate cases, try to use the non-absorbable in selected instances. Otherwise, delayed absorbable good sutures are all available. Apical suspension is a very important thing. I always say apical suspension is important to prevent prolapse, which I have already told for that. And the additional suspension by sacrospinous fixation versus uterosacral suspension. Sacrospinous fixation for long years it was practiced, and my personal experience I will share with you. I had done almost around more than 50 cases of sacrospinous fixation, followed it up, and then discarded the procedure. I feel from the beginning I was thinking that sacrospinous fixation, anatomically, it is not logic. It is not convincing that normally the apex or the valve prolapse, you find that the apex should be at the central part. Now you are shifting to one side, right or left side you are fixing it, or many people do bilateral sacrospinous. How it comes, I am surprised. Bilateral sacrospinous, which area they will fix and all that. So that way it's not convincing for that. Second important aspect, out of 50 cases, more than 50 cases which I have done, about 99% of the cases do present with backache or sexual and dyspareunia. So that's why I didn't like the sacrospinous fixation of this procedure. It's more of a, many people do it, I respect them and all that, but I am in more favor of uterosacral suspension. So uterosacral suspension, sacrospinous fixation has a complications, has a risk of backache as well as dyspareunia. But uterosacral is not always safe also. Uterosacral, you do a correct. Very high uterosacral, there is a tendency of ureteric damage for that. So you don't do a very high uterosacral suspension. You find the limit of the weakness of the uterosacral, and majority of the cases, rarely you find a very high uterosacral. If you go a little above, about 3 centimeters above the uterosacral, it is not going to damage the ureter for that also. And don't go for a full thickness and all that. You go through the piercing the uterosacral, one point should be there, and that is the fixed point for that. And I'm always happy with this uterosacral suspension for that. But apical suspension is fundamental for that. Now, surgical controversies, the special situations like recurrent prolapse, I've already told that the weakness is there, recurrent prolapse. There it needs a place for sacrocolpopexy for that, recurrent prolapse for that. Vaginal and rectal combination, I think you ask the surgeon to do the same procedure in the same sitting for that. Prolapse in a frail patient, again I question who is a frail patient who is not suitable, disease, multiple disease is there, cardiac, all metabolic disease are there and all that, and they are very poor risk patients, surgical risk patients. These are the cases, yes, I agree that you compromise and do the other procedures like obliterative procedures or pessary or something like that. Prolapse with urinary or fecal incontinence, tackle it at the same time in that. And pregnancy with prolapse, again we commonly pregnancy with prolapse, where I have already told about the role of pessary for that. One interesting thing happened during my postgraduate thing and all that. I will just quote it. One case was a grossly hypertrophied cervix, and it's an irreducible prolapse for that with the pregnancy of 16-18 weeks, and a discharge and all that was admitted. And it is impossible to use the pessary for that. My professor told that yes, pessary treatment, you give it the pessary and all that. First, reduce the mass with the glycerin acrylflavin. We used it for glycerin acrylflavin for quite some time. Then it became reducible. Then my professor told that use the pessary. And every time we use the pessary, the next in the morning we give the pessary, in the evening it comes out for that. Again, prolapse occurs and pregnancy. So these are the cases which really gives a real problem for that. So what is the treatment? A fantastic idea came to me, a mad idea came to me that I will suture the perineum. I will suture the perineum, and 3-4 sutures I made it in the perineum after reposing this, and with a non-absorbable suture and narrow it the vagina. And fortunately the pregnancy continued, the cervix was inside, and it continues up to 8 months and 9 months, and absolutely normal. Just the suture was also there, and during the time of delivery also normal delivery occurred, and that we have not done a classical incision, just a suture it and all that. For a temporary period of 2 to 3 months it continued, and then we removed the non-absorbable silk. At that time proline was there, I removed it, and then automatically the delivery, normal delivery. So this is one thing which can be an option for that in addition to the pessary. So Nicholas and Rundle in 1989 have told the choice of treatment. Vaginal reconstructive surgery is concerned with the return of abnormal organ relationship to a usual or normal state. There is no one site or degree of damage that must be repaired or restored. There are many, and they occur in various combinations at various times of life from different etiological factors in various degrees and with various degrees of symptoms and disability. So this understanding should be there for treatment for that. So surgery ill chosen and ill done should be converted to well chosen and well done. That is the key to success for that. And we have made surgery safe for our patients. Let's make our patients safe for the surgery. I think that should be the maintenance for all types of surgery for surgeons. And what are the future concepts? Future concepts could be in future, it could come out, and I'm sure it will come out. If it is today, it seems such a fantasy. and fantasy is the beginning of innovation. I believe that. Muscle regeneration could be there. Nerve regeneration could be there. Tissue engineering, use of cell transplantation, material science and engineering to create a biological substitutes that will restore function. And neuromodulation, robotics has a very enormous place in future, and time will say how far it is effective for that. So future surgeons will use materials that have increased benefits to patient as a result of their sophistication and specialization through tissue engineering. And future physicians will complement their management with pharmacological agents specific to the patient's genetic makeup and metabolism. And that will be a blend of surgeons and physicians so that we find a new world. And the greatest wealth of a professional is acquiring a good technique that I've already told. And the skill is important. Skill is a paramount thing. And that is the basis of this surgical skill transfer program by Juventus Initiative in the different episodes for that. But whatever, I'm always reminded of Bacon's statement, Francis Bacon's statement, read not to contradict and confute, not to believe and take it for granted, not to find and discourse, but to weigh and consider. This is how I told, this is my way of doing things and all that. You weigh and consider, you maybe a different techniques for that also. Everything, you are right, I am right, you are right. Not that I am right, you are wrong. Everybody has a really a scope, and you think about it, every human being with an average intelligence can become really a super intelligent man for that. Now, surgical procedures, the videos, little videos and surgical procedures, I will just enumerate on all that. Now, this is a case. This is a case prolapse with cancer cervix. This case presented to me, and this was decided. The operation date was fixed to be a vaginal hysterectomy with pelvic floor repair somewhere else. When I saw this patient, the date was fixed. They came for my opinion. I found the entry lip of this cervix. There was a small unhealthy thing, but not clearly a cauliflower thing, but it seems like a myoma. I think these are the cases where you should screen it, preoperative plan it. When I did a biopsy, I find a squamous cell carcinoma. And see, these are all preoperative evaluation, which again, I will say that is how important it is. Now, this is a case where we find that on examination, the records, previous records say that large cystocele and first degree descent, cervix is just peeping at the introitus and all that. To me, when I examine, it is not a case. It's just a characteristic, the keratinization of the vagina because it's exposed for a long time. But it seems that it is not a case of bladder. It is a case of the vaginal wall cyst, which simulates like a cystocele. I think see the procedure, and these are books have written the differential diagnosis as the vaginal wall cyst as one of the differential diagnoses. And this is one case where we have done it for that. And this is a case where the vaginal wall cyst, you can see that it is dissected and the proper plane after giving a hydrodissection and then repairing this. And this, unfortunately, this is a case, this case suppose would have been presented, completed family and age more, then we can go simultaneously, same sitting as a vaginal hysterectomy with pelvic floor repair. Because it is a young patient, para 1, with one issue and all that, and 28 years old. We did a conservative surgery and we just do a cystectomy, and with good hemostasis, we left it as such. And it was a first degree descent, cervix first degree descent. It is not a problem. There doesn't have any problem for that. But main thing is that you go with the proper plane. Diagnosis is important, and how it is confusing with the cystocele, you can find out. A dead space closure is important. And while dissection is also the extent of the lesion in the vaginal wall cyst is unpredictable. And how deep it is becomes unpredictable. Here you find how deep it has gone, and that's why there is a need for the closure of the dead space for that. And this is important for that. And you just have a hemostatic suture and close it, and that. So remember that this is differential diagnosis which is there. All cases do not have the prolapse cystocele. All projections, all bulges are not cystocele. This is one example of all these. and you just repose it, and with a good plastic sense, you can do it for them. This is a case again. This is a case which presented with amenorrhea and amenorrhea following a surgery and following it. She gives his history of hysterectomy. Amenorrhea is there, and she gives clearly an indication of a hysterectomy, but something coming down. When I find that it's a cervix which is coming down, again I have to verify whether hysterectomy has been done or not. The sonography doesn't reveal the presence of the uterus, and I was really confused what is to be done. And there was no reports which is available for that also. Some operation has been done during the time of delivery, and I asked whether it's a hysterectomy, subtotal hysterectomy. Then I could find there is a, because of the bleeding, they did the hysterectomy, and subtotal hysterectomy has been done 10 years before. 10 years before, and now she is presenting. She is around 40 now, and she has presented with this sonography. His uterus was not there, but cervix was clearly there. So the same manner I did the same thing with the inverted V incision or inverted T incision, whatever it give it, you give it, and go through the proper cleavage of the vesicovaginal space in a bloodless space, and just don't remove the more of the vaginal tissue for that. You approximate from the beginning. You find out what are the tissues is go, and dissect the. If you dissect to the proper cleavage, the bleeding will be less, and the importance of the vesicovaginal space is important where you find out. And on the left side, I've used my left hand. Although I am used to both hands, I'm not a left-hander, but it's relatively easy. And if I practice with the use of the left hand, it's almost easy in this particular aspect for that. You go to the proper cleavage, and the bladder is there. You make an incision on the vesicocervical ligament and bladder pillar on either side, and completely reflect the bladder, and then the posterior, as usual in the case of all these vaginal surgery of prolapse repair or hysterectomy, or most surgeries for that. So you go to that proper repair and all that. Really, these are the cases where there is a risk as you go up and up, because the problem occurs because there is a previous history of surgery. You expect the number one, that bladder. Number one is the bladder reflection. Second is at the highest level, at the distal part, there could be adhesion, unpredictable adhesion at the distal part. You take a proper care, and vaginal surgery is not a blind surgery. You just see and cut, don't cut and see. And that is the rule. And you find that, yes, I'm going for that in a proper plane, both anterior and posterior, dissect it, and find out the space for that posterior dissection. This is the uterosacral on the both sides, and this is the posterior fossa abdominal. We find that this is the fossa abdominal. We have not opened up the, now it's open. Now it's open, it becomes EG. Once it's open, it becomes EG for that. So, and that second important variety is that you identify the enteroceal, so that high plication for that. You go, then you can find under vision, you can find that there is no adhesions and all that. Even if there are adhesions, you just put your finger in the posterior aspect and come out anteriorly, and you can find the whole of the cervix as expected. You can find the cervix there, and under vision, you just have 2 clamps and remove this whole thing and fix the uterosacral to the vagina and repair of the anterior vaginal wall with the rectocele for that. That's sufficient for that. This is a very atypical case where you might be at some point of time you may find it. This particular case, any one of you may find it, or this is in fact 3 cases in total in my lifetime. I have got a stump which has prolapsed into it, and out of which the difficulties at the distal end we find more, but otherwise it doesn't create any problem for that. And you find by putting 2 clamps, the whole of the stump is out. And remember, the stump, there are 2 risks: stump prolapse and stump carcinoma. These are the 2 things in post-hysterectomy, subtotal hysterectomy. These are, and therefore, the total hysterectomy, many people prefer it. But still, for the sake of saving life And in emergencies, there is a place for subtotal hysterectomy. There is no doubt about it for that. And these are all uterosacral and Meccan rods. And this is to be ligated. Then this acts as a fixation point, and this anchors to the vagina. And this is the second clamp. After this, whole thing will be out, and you are free. You can put this, fix it, and do the, yeah. Now everything is out and is well done, and you fix it with that. The whole stump is out, and you find that is absolutely free. And my daughter is assisting me, and then absolutely again same thing has to be done. You just ligate the upper pedicle, lower pedicle, and the lower pedicle you make this attached to the vagina and fix it, anchor it to the as a suspension. I think this is important. Otherwise, again, there will be a recurrence of the prolapse for that also. So this is important. After the bladder repair, you just fix it to the highest point of the vagina and just finish it, and the patient has an uneventful recovery for that. This is a rare case, and that's why I wanted to show you. This is a age-old. People are forgetting this operation, Fothergill's Manchester repair for that. Now people, majority of the people do the vaginal hysterectomy with pelvic floor repair, but this surgery, I think that most important plastic sense is required in this type of surgery. It is better, it is easier to do a Manchester, it is easier to do a Warmose operation or a vaginal hysterectomy with pelvic floor repair, but Fothergill's Manchester repair is important. The steps are dilatation with or without curetage. Here the curetage I have done it, not for histopathological studies, but if there is a previous menstrual abnormality, do it before surgery. And this is done, suppose this is done premenstrually, and therefore again the bleeding will, with the next menses, the bleeding will be there. That will confuse without secondary hemorrhage, and that's why the dilatation is a must. Dilatation is done for the reconstruction of the cervix, to put the needle, and therefore these are all Fothergill points. The lateral point about 2 centimeter above and lateral to the external os, and on either side you find the cystocele, the bladder is come out. We usually normally give 1 in 1 lakh adrenaline dilute, and this is important. Then the surgeons, either you can give an inverted T or an inverted V. I think this is important. Anything or a linear incision you give it, and now initially you can give a longitudinal incision, and then keeping the surgical, I think the vaginal mucosa, later on you find out, assess how much is required for that also. But I'm always happy with that. I don't believe that you are losing more of the tissues for that. In my which I have initially, you don't make it a penile vagina, but definitely some sort of removal is helpful for that. I have seen people using that, and subsequently that vaginal mucosa persists, protrudes, and all that. That behaves like a again a persistence of the prolapse. So this knowledge of entering into a proper space is really by experience you can get it. How deep you can go. You cannot tell that this much depth of measurement of 0.5 centimeter or 1 centimeter. Every vaginal tissue, every tissue is different, and depending on the keratinization and all that, you find one easily dissectable tissues, and that is the plane. That is the plane where you can go it, and infiltrating with the adrenaline or simple saline also. If the patient is hypertensive, simple saline also, that can solve the purpose. And with the bipolar also you can use it. Many people say that cautery over the bladder. Cautery can be used over the bladder, the bipolar cautery, and don't burn the bladder, but for the vessels you can use. There is no harm of using the bipolar cautery over the bladder, because hemostasis is most important for that. So this is how you just go on the side and all that. You find the pubocervical fossa, so that will give a strength to it. You have to give a base on that, so that that over that the support will be the rectocele, support of the bladder will be there. This side, left side, I always do with the left hand. Right side, I will do with the right hand. And main thing is that you retract the bladder upwards. So this is an anterior colporrhaphy. We do it as cystocele repair. Is a must in a case of And before that, you find out the length of the cervix for that. Normally, in the second degree descent, this type of cases, the length of the cervix, supravaginal elongation is about 4 centimeter. So, if the supravaginal elongation is 4 centimeter, you amputate the cervix up to 4 centimeter to resume the normal length. And remember, you always have a dissection in the incised wound. You with the scissor, you cut the cervico vesical ligament. So cervical vesical ligament is in the center. You cut it, go to the lateral aspect, the bladder pillar, and then use the blunt dissection, because many people use the blunt dissection from the beginning, and that is not going to the proper plane that goes to the rough to the entry. So once you have a incision, you can find that which is best for that, and over that you can finish it. And the limit of the extension of the bladder you can find out for that. So if with the length you remove a 4 centimeter, you can go 6 centimeters, so that 2 centimeter extra you can have it to build up the reconstruction of the cervix for that, because this needs a good attention for that. And of course, the hemostasis, as I told, is important in all cases. Even the bladder also, the bipolar can be used for that. And then you have to do a reconstruction. This is an anterior culprit. So dilatation with or without the curettage. Second step is anterior colporrhaphy. Then third step is the McEnroth's ligament. The second, the position cutting short the McEnroth ligament. So McEnroth's uterosacral, you just grasp it. The posterior dissection. After the posterior dissection, then the shortening of the McEnroth ligament. So if you cut it and then suture it either in the front or opposite to the other side, then the uterosacral McEnroth ligament can be opposed for that. But before that, you just want to reconstruct it, the reconstructed flat. We are using the autologous thing. Be very gentle about it, and they don't use this much tissue. If the tissue, this tissue is lost, no, you cannot have a good repair for that. So because you have to cover the new formed cervix, and new reconstruction of the cervix is important, which is a paramount and one of the most important step in the further repair. And second important step, you are going for a posterior dissection. You must open the posterior pouch. You must open, because ill done operation and ill chosen operation, I have already told, you must open the posterior pouch. Now the posterior pouch is open. Many people do not open this pouch. If there is a long posterior pouch is deep, I think that is the point. Now you find I have dissected the posterior hernia pouch, and that is a deep pouch. If you left it alone, that is a point where again recurrence will be there. Second important aspect, you can oppose the the Mackel's choldoplasty position of the uterosacral. This is important. So both the uterosacral, 2 or 3 sutures you oppose it on both the sides. So this is an opportunity to give a closure for that and good support for that. So uterosacral apposition, both 2-3 sutures you give it, and then a bursting suture you give it and close the cul-de-sac. And after that, so this is the main purpose. This is the main purpose of identifying the uterosacral and opposing it, and then the bursting suture taking a highest bite on the posterior peritoneum. So obliterate the sac, hernial sac. This is the main aim. Otherwise, again, there is a chance of recurrence with the posterior aspect for that. It's not very difficult procedure, but the knowledge and ideas should be there, and before the decision should be there to open up that. And always, I always say, if you are doing a further repair, you always try to see that the posterior pouch. You cannot know what is the limit. At times, you don't find out the place. At that time, this is a different issue. But majority of the time, you dissect it and you can find out that the pouch of Douglas is open for that. And these are series of sutures, uterosacral sutures, and the midline, and that can give a good protective effect, suspension effect for that, and prevent the prolapse, the recurrence for that. And then you just go for the closure of the pouch of Douglas. Closure of the pouch of Douglas by, you can see the pouch of Douglas, you give a closure for that. And a redundant portion of the peritoneum, the hernial sac on the posterior aspect, you can remove that. You can excise and remove, so that you are, this is the redundant portion. And you are giving for a highest point at the level of the posteriorly, so that redundant portion you can exercise it. So this is the bursting suture which is given after the uterosacral, and then exercise the redundant portion of the posterior vaginal wall. I mean the peritoneum and the hernial sac. That is in fact the posterior margin of the hernial sac. Then next procedure is the uterosacral. Shortening of the uterosacral. On the two sides, you take a measurement that yes, I have to remove about 4 centimeters of the cervix, and more so, don't remove. This is the demerit of removal of the more cervical length, and that can give rise to future cervical incompetence. And this is important, particularly where fertility is important and patient is young for that. So always use the vicryl suture for that. Earlier we are using the catgut, but now routinely vicryl is to be used for that. So the mechanoid uterosacral, I have already told that it is from the beginning, the time of attachment, 2-3 centimeters is all same. On the two sides is there. Then putting a traction on the cervix, you just slowly do a encircling incision, cut the amputation of the cervix. This amputation, don't put a guillotine incision, everything will be there. If you put a traction and slowly you give it, the purpose is that ultimately it will be conical. The purpose is that the conical cervix will be there, the reconstructed cervix will be much better for that. It's not a flat cervix at the proximal end. And now this is a method where you can do it. Slowly you give it so that it forms like a cone. The part retracts, the fibrous part retracts, the inner part projects out, and this forms it. And this is the posterior vaginal wall. In the middle part, posterior reconstruction. The posterior vaginal wall is reconstructed. This is the Sturm-Down procedure. Many people do that in a separate leading, but I do give it two, one anterior, one posterior. And there are some persons who give a serial closure and obliteration. That doesn't look nice for that. And for that, it's a classical for that. So you go again in, out, first out and in, then in, out, and then of course, and taking a very, why I need a plastic sense in the central part so that equidistant you find out. So the posterior reconstruction of the cervix is done with the vaginal flat for that. And this is very, very important for that. And you find a hypertrophied cervix, a very ugly looking cervix, you do it after that procedure, it looks like a nulliparous and nulliparous cervix. This is an anterior stummed off where you find first a vaginal wall on one side, then you take a bite from the sutured mechanoid uterosacral, then from the cervix, anteriorly part in the central part, from out in to the inside in the cervical canal, and that is the necessity. Now you feel that dilatation helps us. Then the in and out, then the other side, the vaginal, the uterosacral mechanoid complex, then the vagina. That is all. The two sutures and one on the anterior and one on the posterior. You find that absolutely that will cover whole of the cervix, and good reconstruction of the cervical thing will be there. And of course, a good take care of the hemostasis. If there is a blood and all that, if there is vessels, you coagulate it and take care of the proper hemostasis. Now, this apposition needs a good plastic system. How much tissue has to be removed and how much tissue has to be done, and which part I will hold it with this suture. I think that's important for that. So this is fixed directly. The vaginal reconstruction anteriorly is done, and again we find a good length of the portio vaginalis by taking a bite from the 3 centimeter above, and then you just remove. So a series of sutures in the front you can give it, and so that you can find a good external os, region on external os and all that. And then this procedure is completed. After then we go for enterocolporrhaphy, the bladder repair, and the vagina you pose for that. We don't remove much of the tissues here. Initially, whatever tissues is removed during the time of dissection, from the beginning we have done it, and then we have not done another excision for that. And this is a thing which is a Fothergill's Manchester repair. Unfortunately, the cases are not very common. When I find it, you see the whole thing, the earlier cervix, it is almost a nulliparous look and all that. You see how beautiful the nulliparous cervix is there. And this is how with the 2-stitch, not a very complicated procedure. And then the rest of the part, as in a colporaphy procedure, you do it for that. So this procedure of the cervical conservation of the uterus is a young age, needing for a conception. And so see, once a baby in a young age with a 2nd-degree descent, with a grossly hypertrophied cervix, I think this is the best procedures for the repair, is one of them. This is again a procedure where the nulliparous prolapse, the cervix is out about 4-5 centimeter outside the introitus, and this nulliparous prolapse, this is a young girl of about 19 years. She told that, yes, I'm having really a problem and always outside and all that. 19 years old girl. So she was very uncomfortable with that. So this particular case can be tackled either by abdominal cervicopexy or can be tackled by laparoscopic mesh, by hysteroscopy, by the hysterocolpopexy, where the sacropexy, where the mesh can be used in addition. You fix the mesh to the posterior part of the cervix and retroperitoneally bring it to the sacrum and stitch it in the sacrum, or tack or use it. That is acceptable for that. And make it retroperitoneal, again we have to go for that. So this is one approach in which we can do it. A mesh can be acceptable for that. But I am not in favor of mesh always. Somehow I have from the beginning, I don't like mesh accepting TOT mesh. TOT is acceptable for me. TOT mesh is acceptable for me. Or a recurrent prolapse, I have done few cases of the sacrocolpopexy. But otherwise, vaginal approach is always best for me, and autologous repair is always best. So this case, I've used the autologous tissues, and always the incision should be always a transverse incision. It cannot be abdominal cervicopexy. This is known as either a Purandarese operation or a Khanaj operation. Khanaj operation takes only one, and Purandarese operation on 2 either side from the midline, 2 flaps of the. As we go in the normal case, we do for a cesarean or for an abdominal hysterectomy, the same procedure. You just go and dissect the rectus sheath and dissect the lower half and upper half. The upper part of the rectus sheath should be a little exposed more, because we want to take 2 strips of the rectus sheath on the upper part, and hemostasis has to be maintained for that. Good hemostasis has to be there. The incision length should not be more than 15 centimeter, and it should be transperitoneal. It should be transperitoneal. It's not an extraperitoneal approach. It's the pyramidalis muscle which I have incised and reflected. And this I always in a transverse incision go and separate the pyramidalis. Don't try to disseminate. It may be cesarean. It may be any abdominal operation. I think don't remove it from the months so that persistent pain, bleeding will be there for that. So dissect the pyramidalis from the rectus muscle, and that will give a less of bleeding. That will give a less of postoperative pain for that. And now you enter into the abdomen. Before entering into the abdomen, this is a step where you take a strip. So this, you dissect the rectus sheath. I am going to take 2 strips of rectus sheath and cutting in the midline, right half and left half. We just dissect and take about 1.5 centimeter breadth tissue. This I am cutting from the midline. Can you see that I am cutting from the midline? And then extending it 2 on the either side. This is just 1.5 centimeter width, and from the midline, the lateral part is attached. This is lateral part is attached. Lateral part is attached because that will come as the. Can you see that? That this is the left part, this is the right part, both part. Then enter into the peritoneum. Enter into the peritoneum. Then the next step is that hold the cervix, hold the uterus, and identify the, go to the uterovesical fold of peritoneum. And find out a site. Which site is there? I think it's the lowermost part. I think go as low as possible at the level of the isthmus. you must select that. Otherwise, if you go higher up, not be any problem for that. Now you lift it. Lift the uterus in such a manner, pack it up posteriorly. Everything is normal. In the interior part, you can see the uterovesical fold of peritoneum, and just stretch it at that point and identify. You open up the uterovesical space, dissect the bladder low down, because I want to go and fix it at the level of the isthmus. You can find out that. So now this is a uterovesical fold of peritoneum, and we go and dissect at that particular plane. There's a very avascular plane, and you can go and find out the portion of the anterior part of the cervix and fix that part, and that rectus sheath will be fixed to that part, particularly in the lowest month. And you can find out from the posteriorly also. You can feel it with the hand, that uterosacral attachment where is there, and posterior hand will feel it. At that level, you can go as low as possible and fix it, so that the whole thing can be lifted up on that. After clearing the uterovesical fold of peritoneum, next is the step where you bring from the two flaps from either side, lateral to the rectus muscle. And this is very, very important. You guide it, how you can go through that. I will show you. The video is self-evident for that. And this posterior evaluation and comparison of this will give an idea as to the lower limit of the cervix, so that at least you can say that 2 centimeter, 3 centimeter supravaginal part, you can, the infravaginal part, you can leave it, and supravaginal point, you can select it for that. At least 2 to 3 centimeter, you can go for that. Fine. And now that is the part, and that should be depicted, the identification, the filling, where it is to be there. That is the primary thing. Now this is important. This is the round ligament. This is the round ligament. You see, you hold with one of the artery forceps and go below the level of with a long artery forceps or a clamp. You go just below the level, dissect below the level of the round ligament. Follow the round ligament and go below the level of the round ligament and follow it extraperitoneally. So that below the round ligament, if you follow it and pierce it to the lateral margin of the muscle, rectus muscle, pierce it to the muscle, and automatically you will find that it is piercing the, it is going in extraperitoneal, not the intraperitoneal for that. So this is the one method which you do it on both the sides and all that. And you can see that the clamp, while dissecting on that particular aspect, you go, and main thing is that by retractor you can find that it is not piercing the peritoneum. So normally you go in such a manner and follow the round ligament wherever there is an insertion in the lateral part, I think internal ring, I think that is a part where you pierce it, and that will automatically go. The only thing is that it create a space between below the level of the round ligament. And remember, this is the part which very clearly shown that. Now this clamp I am piercing through the lateral. It is coming through the lateral part of the rectus sheath, and there the portion is there, the flap is there, the rectus sheath on the one side, and it has come out. Be sure that it is not slipping and all that. The one side is there, the next side is there. The two sides you just fix up with that selected point on the anterior surface of the cervix and stitch it with that. And that either you can go initially, we are going for a non-absorbable suture, proline or silk or something like that. But I feel that the simple vicryl reinforcing another time, 2 times suturing is enough for that also. That is the only thing. The trick is the extraperitoneal. The trick is you remove, you don't injure the vessels in the lateral epigastric vessels and go through the lateral aspect of the muscle and suture it properly. So that is the only thing. That is the only trick for that. Again, the other side. This is the one side you have seen. The other side, again, we are going for that. And after doing the procedure also, you must again see that it has not punctured, it has not gone intraperitoneal. That is the only trick for that. Whole thing should be extraperitoneal for that. So the same procedure, because I'm doing, even if I'm using the autologous procedure material, can you see that this has come out and testing that it is in extraperitoneal. Because these are the cases which is not that uncommon, but still it's difficult, and that's why I wanted to show in detail. These are unedited videos, and that's why it's taking a lot of time. But however, you see, and then if you see for the youngsters and all that, those who have never seen, for them, I have not edited this a complete video. Even if the time is taken, I must show this. Because laparoscopically, you have seen the procedure by mesh. I have also done mesh procedure with this. Somehow, autologous, I'm very keen on autologous for that. And mesh problem is now they're very so now this at times what happens, this slips, and again you have to go for the women. But be careful that you apply two things. One is a Ellis tissue forceps, another is and the artery forceps. Both I kept it. If at all it slips, one slips, the other thing is there for that. It's way back in 2007. I've done this and recorded this, and this is routinely I was doing, and of course mixed combination. I've done laparoscopy also. I perform, but this is a procedure which is done by common gynecologist, and anybody can do this procedure for that. So here, the point selected where you fix it, you take it one vehicle point for that, and then one bite to the one part of the one half of the one side, right, left side, you just give it, tie it, then go to the other side, so that once it's fixed, you can reinforce with another suture for that. Fine. Now the other side is also there. You can reinforce that with that. You can also use the non-absorbable also, either polyamide or proline, you can use it, or polyamide, you can use it for that. The other side, you just fix it at that particular point. And I feel that only vehicle is also 2 times you just fix it at that level. That is enough for that. But the polyamide, you can reinforce it also. This is a permanent. Don't think that is a next time doing a cesarean section doesn't have any problem, because the cesarean scar will be high, much higher than this level. Because that's why I told that you just give it at lowest point, about 2.5 centimeter above the external os. You fill it with the posterior margin of the uterosacral, with the posterior hand, and then this is a reinforcement of the second layer for that, and reinforcement of the second layer, and that is absolutely all. And you find that now the uterus is at the level of the umbilicus, not at the level of the umbilicus. You find the cervix is drawn up, and remember that the checkup, when to know that it is a successful surgery. You inspect in the postoperative period, you find that the cervix is gone up, and the test for real surgery is that you just put a speculum, you find that the cervix has gone up, I think at the level of the ischial spine or above the level of the ischial spine, and ask the patient to cuff, and during the cuff you find that the cervix external os is still going up. So during raised intra-abdominal pressure, during cuff, the cervix rises up, and that is why, and then we find that this is a successful cervicopexy. This is the test postoperatively. You do this test, the cervix has drawn up for that. So peritoneum, you just reperitonize it and examine that the uterus. This is a very good surgery. I've done a couple of cases. I'm very happy with that. And also mesh also can be an option for that also, but the mesh, the demerit which I found that about 30% of the cases of mine, I had a relapse, recurrence, which I have to again do that. And the talker is inferior to stitch. I have compared that if you are giving a talker and all that, it will slip. And if I prefer that after the talker is easier and is better given and easily done. But subsequently after the recurrence, I feel that I converted into stitching, and serial stitching of those could be there. But still is in my mind is the mesh is there in the cervix, mesh is there in the retroperitoneal area, but somehow the recurrence is not there with the stitch procedure for that. But a good procedure by whatever method you do it, it's always acceptable for that. So this is one cervicopexy which is done by the Purandare's method, nulliparous prolapse, which is having a good result by common gynecologist. Anybody without any endoscopic experience also can do the procedure with that. It's not a very difficult procedure. Now this is another case which is a second degree descent, and we find that we have done a line diagram where the anterior wall prolapse is more. The posteriorly is not much. There is no rectocele, the lower part, there is no rectocele and enterocele, and the anteriorly the cystocele is more, and apical prolapse is more. So with that line diagram, I think I will plan for, and she's elderly, she's about 42, completed family, and she's having also the menorrhagic cycle. So evaluation has been done, and previous endometrial thickness is not much, and endometrial biopsy reveals proliferative endometrium, and then the same procedure. The main thing we find, I have already told that the identification, before that you find out the level at which you give it for that. Don't go for a wide margin and excise it from the beginning for that. And I am not always, many people are in favor of not excising the tissues, and so that the functional capacity for that. So I don't agree within the, my personal view over the last so many years of surgery. I have not faced any problem, and the functional capacity, regarding the functional capacity, I don't find that I will just enucleate. But this much tissue, if you do not remove it, I think that is creating a lot of problem post-operatively. And for months together, I have examined these. Some cases I have done it without that, and after 3-6 months also find that there is a bulge, and the patient is having sexual dysfunction, and still the residual thing, and vagina is there, and that on strain also it comes out and all that. So I was not very interested in that. So autologous tissue, as well as the tissues, the removal of the redundant tissue, whichever is required, that I'm in favor of that. So if you go to the proper cleavage, I think the bleeding will be less, and traction and counter traction with that can eliminate the whole procedure for that. And that is the same thing. And of course, this is a vesico, this is cut it, and then the side walls, the two sides as usual, you dissect it to find out the pubocervical fossa for ultimate repair, and putting a strength and a breeze in between, because normally you can put it side to side, a series of sutures along with this thing, or you can, in the large cystocele, normally I have a preference of combining one bursting suture, and along with that the strengthening of the pubocervical series of sutures along with the bursting. So that is much better than simple bursting or simple side to side. So that is important. And bursting suture, when you take the precaution of taking a particularly identify it's very difficult to identify which is a pubocervical fossa. It's easier by theory that telling that yes, it's a fossa. But remember, the plane in which you go, that is the plane of musculofibrous layer of the skin. And skin has got first layer is a stratified squamous epithelium. Next layer is a lamina propria. Third layer is fibromuscular layer, and the last layer is adventitial. So that layer, the fibromuscular is same as a vesicocervical, pubocervical fossa, and that is a condensation of the endopelvic fossa. You take it, this is a cervico-vesical ligament. You cut it in the center, nothing will happen, and then go through the lateral pillar of the bladder. This is the bladder pillar. You cut it, and if you reflect it up, I think there's little chance of you go to the proper cleavage. There will not be any bleeding for that. And bladder pillar, there is a little bleeding. You just coagulate or ligate it and all that. That is not a problem. But remember, a cystocele while doing a entry repair, it's just a apical repair. It's not a paravaginal thing. It's a central part, and the posterior part again will do the same thing. Posterior part, same thing will do that. And the only thing is the Ellis which you find at the central part, that you keep it open. On either side, you put a different part, instrument, either if you are putting a Ellis in the central part, put 2 artery forceps on this, because at the end of the surgery, you will confuse with that. And so in different suture, different instruments, if you put it, you can identify the central part for that. That is the practical tip. And because at that particularly lowermost central part, we have to fix it. So at the end, we have to fix it in the lowermost part with the mecanodictosacral, and that is the endogenous support, the autologous tissue support and endogenous support for that, and that you find out that this is the part in the central part, is not in the lateral part for that. So go through that and find out the pouch of Douglas. If you open the peritoneum, at one point you find the peritoneum is open, otherwise you can fill the peritoneum and cut it, and that is the part where you enter into the pouch of Douglas for that. You hold it with that, that is the part, and cut it, you can find out. Can you find out that this is the part, you hold it and you can clearly go. And with the finger, you can insinuate and find out and go reach the upper level in fundus and then bring it out. So in some cases, when there is a long supravaginal elongation, the length is so much that you are not able to get it. Here we can get it with that. Here we can get it, and the anterior part, you dissect it and find the fundus. But in some cases where there is a very elongated cervix, you don't get it, so don't try to get at any cost. You go from below upwards. You just start rather than going from above downwards. Here we want to go above downwards, 3 clamps on either side. The highest, the clamp, the middle clamp is the uterine artery, and the lowermost clamp is the uterosacral for that. So instead, we go through the upper part and all that. We go through from the lower, we go upper, because the cervical uterus, the supravaginal elongation is so much that it is not approachable. And here, while putting a clamp, go like this, not like that earlier. This is the wrong way. So this is a part where we get it. So if you go more transverse, you are liable to include the ureter. So remember that there is an oblique clamp from below. So this is putting the mecanodictosacral clamp for that. And on either side, you just find it out. And on suture, you just suture it, and good hemostasis is there. Then the same procedure of closing the vault, the closing the peritoneum and opening, and then fixing the uterosacral to the lowermost part of the cervix, which I mentioned that, and that is a very good source of fixation for that. The uterosacral mechanod is a very good source. Sometimes in some weak case, for example, in a presidencia, I use the upper pedicle also. The middle pedicle is the uterine. We leave it as such. The upper pedicle and lower pedicle. Lower pedicle is fixed at the lower level, and the middle pedicle in the mid-vaginal level, we fix it for that. And that fixation is very helpful for that, and that completes the procedure. Here, there is no posterior vaginal wall prolapse, so no need of a pernuraphy here. So only the anterior, the addressing the uterus, addressing the cystocele apical segment and anterior segment is enough for that. And that is the solution for that. Otherwise, if there is a posterior thing, the classical Watermose or vaginal hysterectomy with pelvic floor repair has to be done. Along with this procedure, you do a pernuraphy for that. You see how length of the supravaginal portion here, the classical in second degree, the length of the supravaginal elongation is occurs, and that is mainly due to the venous stasis and the traction counter traction effect of either side for that. Now, this is a classical VH with the PFR and all that, and here anterior prolapse is there, posteriorly there is a prolapse, apical is there is a prolapse. So rectocele is there, anteriorly the cystocele is there, and here we find a long supravaginal elongation, very long supravaginal elongation, 45 years old, multiparity, about she has got 3 issues, and the same procedure. The procedure is all same: hemostasis, then the hydrodissection, the separation of the bladder, then situation, then the anterior colporrhaphy, the removal of the uterus either by the 2 methods, either from the below a long cervix we go, and from the uterus sacral till the upper segment we go, otherwise from the upper to the lower segment we go. So this is a classical VH with PFR. Normally what we find that if there's a no descent, we apply the term vaginal hysterectomy. When we say that vaginal hysterectomy, it is presumed that it is a non-descent. When we use the PFR, it is presumed that it is a case of prolapse. So in a prolapse, simple hysterectomy is not the answer. So remember, in a prolapse, we have to do a pelvic floor. We have to target the pelvic floor repair, either depending on the which side, whether the enterovaginal wall or the postovaginal wall or enterocele, rectocele, which is there for that, we do that. So this is one example of PH with PFR. This is the wall prolapse. Now, wall prolapse, I will take a little time. Wall prolapse, there are post-hysterectomy wall prolapse. How to tackle it? The method is either a vaginal repair or an abdominal repair or a laparoscopic repair. The abdominal and laparoscopic repair, the wall prolapse is just put the colposacroplexy. So sacrocolpoplexy is the method where the wall prolapse can be there by laparoscopy or abdominal. So abdominally, the same incision can be given. Expose the sacrum and dissect. You push it with the sponge holding forceps, the highest point of the vault, and vault, you dissect it anteriorly and posteriorly. Dissect the anterior vaginal wall, dissect the posterior vaginal wall for 4-5 centimeter, and place the mesh anteriorly and posteriorly in a bifid manner, and then go through the extraperitoneal method, extraperitoneal space, and fix it with the sacrum. I think this is one, either same procedure you could do it with laparoscopy or with the laparotomy. But I prefer, personally, I prefer to do it vaginally, so that addressing the vaginal thing, the loss, and again with autologous tissue. I don't want to use the mesh for that. I don't believe that the tissue, if you are meticulous, you can keep the tissues and organ preservation and the tissue with minimal excision for that. And I am not going for totally don't excise. I don't believe in that, and I'm not unhappy with the procedure. So main thing in this procedure, anatomical repair of the vaginal repair of the wall prolapse, the cystocele is there, the rectocele is there. You have to identify the clear it whole procedure with the correct plane. That's important. Otherwise, there is a chance of the bladder injury here. You are not able to know here which is the lowest limit of the bladder. So that is the main part. So incise it, and a rhomboid shaped incision. You go anteriorly, reflect the bladder on either side as done in all cases, and then posteriorly rhomboid shaped incision, and then you have to enter into a space, not in injuring the bladder, and you have to enter the peritoneum. That's important. Once you enter the peritoneum, the things is easy. So at that point of time, you just find out that which is the bladder and which is the rectum, and the tissue can identify. The tissue will tell you which is the lower limit of the bladder. If you dissect completely the bladder all around, cystocele, anteriorly, laterally, and posteriorly, you can identify what is the lowest limit of the bladder. That's not a very difficult problem, but that attention has to be given for that. Now, if you dissect on all sides, if you don't dissect and put it, then there is an injury for that. So dissect from all sides, and then you can know which is the part. And you go through the same plane, and take a precaution. You can put a bipolar. You can put a bipolar. Yeah, that's a. After dissection, you can find out that which is the bladder, the lower limit of the bladder, and then rectum, which is the lower limit, and then incision. You can find now. You can find now that clearly that is the limit. And if you hold it and cut it, that is the limit you are going through the peritoneum. So trick is important. You have to go through the peritoneum, and after going to the peritoneum, then the bursting suture has to be taken. And here what I find, I always use the uterosacral method, uterosacral as the point for that. Now I'm happy that you have entered into it. This most important, very simple way of tackling this wall prolapse is not by sacrospinous. I'm not happy with the sacrospinous. I catch hold of the uterosacral on either side and with the Ellis forceps and drag it. And which is the part which is the strongest part and which is the weakest part, I could know. With the two Ellis, you just push it, you just grasp it, the two uterosacral along with the peritoneum. Don't take an extra bite for that. And while doing a bursting suture, the same bursting suture, we are closing this peritoneum. You take a deeper bite at the level of the uterosacral, which the Ellis holds, and give a bursting suture. And that two thread, you take a long, and that is fixed to the vagina. And ultimately, when at the end of the procedure, when you tie it up, that part is central and goes higher up and all that. So this is how the wall prolapse is a new method. I have done it, and almost many cases. This is how the new two Ellis, you have seen the limits of the uterosacral. Limits of the uterosacral, the two Ellis I have seen. I've taken a bite here. You can see the little deeper bite in the uterosacral, and it doesn't have any problem in taking the ureter for that also. I'm not taking a very high uterosacral. High uterosacral suspension, there is a problem. And the highest point of the posterior peritoneum, you take it so that excision of the hernial sac in the posterior part. And you can see that this same bicryl bursting suture, taking a uterosacral on either side, and don't need a separate, you can take a separate uterosacral, two uterosacral, and fix it to that. That you can do it also, but it's not necessary. I find that a couple of cases, almost around 25 cases, I've done it with that, and I'm happy with this procedure for that. And vaginal always with the restoration of the sexual function also. Now this ends of the procedure. This is the main thing which I wanted to show you in the wall prolapse. And of course, the cystocele repair, at the end you do it, and you can do the penuraphy also with that. Now this closure, this suture is important. You close it and keep the suture long. This suture will be fixed to the Ellis forceps in the middle part, so that will in the center, in the apex, that will go higher up. When you, at the end of the procedure, when you tie it, when you fix it, automatically you'll find that the whole intravaginal wall is going anteriorly in the middle part and central part. That is the key and all that. And rest of the procedure is all the same for that. Now this is another case, posterovaginal. The complex prolapse is a posterovaginal wall prolapse with the rectovaginal fistula. I think this is a case where rectocele is there, enterocele is there, with the fistula is there. There a long-standing rectovaginal fistula is there, is identified. So I had tried for both in the same sitting, the rectovaginal prolapse RVF repair with the posterior compartment defect. I will just do a encircling incision, first tackling the RVF, and after the RVF is closed, it's very simple. That put again the same procedure of excising, going through the dissection of the vagina, removal of that, and going higher up and closing the enterocele repair. Rectocele also, we give a bursting serial suture in the repair in the fossa of Denver, in the rectovaginal fossa, and then a multiple sutures, so we give it, and then ultimately the superficial transverse perineum and a deep transverse perineum, and then the skin is there. And it gives a very good result for that. And vaginal, what I mean to say that if it is a genital prolapse, if it is a pelvic organ prolapse, I think vaginal approach is always best. You can have an access to all these compartments and do the procedure much better, and is the least morbid in comparison to the other procedure for that. Now there is a tendency now that laparoscopy for prolapse surgery, all prolapse surgery cannot be dealt with the laparoscopy. Mesh is an inherent part for that, and that is the complication which can come out for that also. And this you don't depend on the surgeons also, you can do directly with that, and that finishes the procedure. So the complex procedure, I will just, the slides are there, the videos are all there. I will tell the I think the Juventus people are giving the videos to everything and detail of the procedure. You can see it in subsequent thing for that. Thank you very much, all of you. And thank you, Dr. Diwan, for giving me another opportunity of this 9th episode to interact with my viewers and to you and complete the procedure of the genital prolapse or pelvic organ prolapse, which is so common and to the gynecologist and all that they must do a good job and restoring the function and which is satisfying to the patient. I think that creates a lot of happiness to the surgeon. Thank you very much.
Thank you, sir. Thank you very much. And I think this was tremendous energy which you have displayed today. It's a marathon lecture, and it was so spellbound that we couldn't even move. Like, it is really good. And you have the skill to, concise the things in a very specific fashion so that it enters directly into the mind.
Thank you.
So with this, sir, I would again request you to answer a few queries which have come from the field. Sir, Dr. Uma Devi from Hyderabad, she's asking, Malpass classification is much more comfortable for nulliparous type of prolapse, and UV prolapse fills the surgery, further fills the surgery. So any comment on that?
Yeah, Malpass, I feel that for apical prolapse is very simple. The strength is very simply, but the weakness is that it lacks intravaginal prolapse or postvaginal. It doesn't address that, and it lacks the quantification. That is all.
Right. Sir, from Cuttack City, Dr. Bhagyalakshmi is asking that can we use vessel sealer in ward meos?
You can use the vessel sealer in ward meos, but for the fixation after the vessel sealer in the uterosacral Macken rod and in the upper, if you are going for the upper, if you are using only the uterosacral vessel sealer, you can after the vessel sealer you can again catch hold of that and take a bite and leave that suture, and that you can make a strengthening it.
Right. So Dr. Sai Lalita from Chennai is asking, after abdominal cervicopexy, delivery, does it has to be through cesarean only?
No, it's not necessary. It's not necessary. But what happens, particularly where the cervicopexy is done for infertility? Say, for example, there are many cases who have 6-7 years infertility and cervicopexy is done. Before that, what I find, these are the cases I put it with IUI and all that, because I find that is it. But everything is fails. And there we put it and the cervicopexy and patient conceived. There are many occasions where the patient conceived after the surgery, and in that case, by virtue of infertility treatment, you do a cesarean. And nowadays you are liberalizing the cesarean. Not that there is a perfect indication of doing a cesarean, but we are liberalizing the cesarean. And the next generation will say that yes, presence of pregnancy is an indication for cesarean. And what do you say about cervicopexy?
Sir, again a question from Dr. Uma Devi from Hyderabad. Where does supravaginal elongation of cervix stand in POP quantification? Kindly explain.
POP is not related to supravaginal elongation. It is a central defect. Supravaginal elongation is a different entity for that. So POP doesn't account for supravaginal elongation. It's an apical descent that is important. The point, the lowermost part is important. It's not a supravaginal. It's a portio-vaginal. The lowermost part of the cervix. Where is the level for that?
So doctors, Sai Lata from Chennai again is asking, like, do we have to do anterior colporrhaphy in Fothergill's even if there is no cystocele?
Yeah, cystocele, the anterior colporrhaphy, while in Fothergill's what happens, the length of the cervix, uterocervical length is important. In the uterocervical length is normal, it's elongated, then it's easy to do a amputation. If it is small, without amputation also, you can do the uterosacral Macken rod shortening and stitching it to the anterior surface of the cervix for that. And anterior colporrhaphy, if there is a, unless you reflect the bladder, you cannot find the point at which you can take the bite for that. And that is the purpose for which we reflect, even if the not a gross cystocele, we reflect it, whatever tissues is there to make facilitating the reconstruction of the anterior cervix.
Right. So Dr. Priyanka from Dehradun is asking, sir, please guide us what to do in 85-year-old lady with non-reducible prolapse, with rectal prolapse, with urinary retention with painful edema.
Painful
Edema.
edema. Now, exclude some medical causes. Why there is a painful edema? I think that's important. The rectocele and prolapse with retention is not a problem for that. So, and 85 years, you find that yes, if there is a strong contraindication for anesthesia, I'm worried about it. But if anesthesia, there is no contraindication, but age is not a bar for anesthesia fitness. And these I've already told and emphasized on the frail patients for that, the same thing. So you can do the procedure taking help of I've done a couple of cases, Thier's graft along with the vaginal procedure, or too drastic surgery of abdominal sacrohysteropexy along with the rectopexy is difficult. I think the surgeons, you ask that whether if it is done with the simple Thier's, it is all right, but no indication, don't subject for two gastric operations like a rectopexy and hysteropexy. I don't recommend that. And always vaginal is always bad. With the spinal anesthesia, regional anesthesia, you can do the procedure. But main thing is that the edema and all that, you exclude whether there is a medical condition, and surgery is not a contraindication, we do it.
Sir, from Mumbai, Dombivli area, Dr. Ramesh Deshmukh is there, and he's asking how to prevent vault prolapse.
That's what I'm told. Vault prolapse prevention, the apical suspension is important for that. And therefore, when we are doing a abdominal hysterectomy or a laparoscopic hysterectomy, while doing a laparoscopic hysterectomy, you close it the vaginal mucosa, the vaginal vault. I think the angle of the vault, you put a suture on the uterosacral, and that is the best way. And doing the same procedure in abdominal also, what I do, that I always say that yes, while putting the angle, you put the angle, close it, and take a bite again with the uterosacral and fix it with that. So it becomes a double enforcement for that. This is a abdominal and a laparoscopy. During vaginal, what happens? Earlier we are using the circular incision in the pericervical region, anteriorly and posteriorly and the lateral wall. Now, because this is a part where the uterosacral and mecanode are fixed to the lateral aspect, give a transverse incision on the anterior wall, and the posterior laterally you keep it free, so that anterior pouch and posterior pouch you open it, and then along with the vaginal mucosa you just ligate or give a vessel sealer holding the vaginal mucosa intact. So from the beginning we are not separating it from the vagina. That is one part. And while closing also, I always say that if you are going, there are two methods. Either you can do a Mackel's scaldoplasty, or you do on one angle, two angles. What happens? You secure it, and the posterior bite you take a little higher, and higher uterosacral, and then reinforce it. That will be preventable for that.
And sir, what about if it is recurrent? So like, Dr. Vijay Lakshmi from Kandasyam, Chennai, like she is asking, like she had encountered one case who is recurrent. So
now recurrence, what is the meaning by recurrence? Say for example, Fothergill's repair, you have done it, and again you have recurred it, or a vaginal hysterectomy you have done it, the PFR we have done it, prolapse, then it's recurring. That different issues are there. So if there is a Fothergill's repair which you have done it and recurred, and patient has completed the family and all that, I have seen a couple of cases like this. I do the same procedure, the vaginal hysterectomy with PFR with the proper fixation. That's important. And if the vault prolapse is again recurring, the option is again, best option is sacrocolpopexy. I think this is the best option. Mesh, that is the place where mesh can be used for that. Otherwise, you can use the high uterosacral suspension like this. You take a little higher up and do that procedure for that.
And doctors are saying that excellent. We are privileged and lucky to be a student.
Thank you. Thank you.
Thank you so much, sir. But one more question is there. If you allow me, I can read that.
Yeah.
Sir, this is from Dr. Jyotsna Pathak from Patna. She's asking, is uterosacral ligament ligation necessary in Manchester operation, or we can take a bite without cutting and fix in the middle?
Well, Manchester operation, you have seen, I have already told what is uterosacral, what is Macandor's, and what is pubocervical ligament. it is the common source of origin in the lateral part of the cervix and upper vagina. And after 2 centimeter, one goes to the anteriorly pivocervical, one goes transversely the Meckenrods, and one goes proposteriorly the uterosacral. So when you are going and clamping the ligament, you are clamping all the 3. You are not clamping separately uterosacral or the Meckenrod for that also. Clamping all the 3, and then you are reconstructing the anterior vaginal wall, the cervix.
Right, sir. So I think people are very impressed with your bloodless surgery. So
Thank you.
that's so nice. Thank you so much, sir, for your time. And this is time to take now vocal rest. We wish you all
No, it's all right. But I'm getting repeated requests from the viewers. I don't know, from various aspects and all that. Please kindly tell the Juventus people is close to you. Please have a facility of seeing all the episodes in a pen drive manner, so that we have forgotten to see 1.5 we have seen. We have not full seen, and so we want to see the whole episodes and all that. I told them I've discussed this. They will distribute it to all the gynecologists who want it for that, and in lieu of that, you should be Juventus friendly.
Sure. I'll convey the message, sir. In fact,
they will be Juventus friendly, so that you'll be distributing this. Definitely. They have some responsibility. You have some responsibility. So that is a situation where it's a win-win situation for everybody, and they want it. One of my students said that I want to see it regularly. One surgery, suppose 2 hours. I can see more often, and whole of the procedure, the video session, half you are showing it and half is not there because of the lack of time. So that is the request you should find out.
Sure, sir.
Many people want it.
We'll do that.
I was really happy, and teaching is my passion. You are my lovable people, and I will continue to do this.
Thank you.
Thank you, sir. Thank you very much, sir.
Thank you, Aditya.
Thank you, sir.